Good morning. The Subcommittee of Oversight and Investigation today examines the Center for Disease Control anthrax incident last month that potentially exposed dozens of CDC researchers to live anthrax because established safety procedures were not followed. Last Friday, the CDC director announced the findings of CDC's own internal review of the incident and the corrective actions being taken. CDC's review identified a fundamental flaw. The agency had no written study plan to ensure the safety of its workers and the proper handling of live biological agents. Like anthrax, the Department of Agriculture's investigation revealed more disturbing detail. During the inspection, CDC workers could not locate some of their anthrax samples. It took more than a week for the inspectors and CDC management to track down the anthrax samples that are in CDC's custody. Agriculture inspectors also uncovered that CDC was transferring dangerous material from biological containment labs in Ziploc bags. Disinfectant that CDC labs use for decontamination was expired. This is troubling, and it is completely unacceptable. The Center for Disease Control is supposed to be the gold standard of the U.S. public health system, and it has been tarnished. We rely on CDC to protect us and uphold the highest standards of safety. But the recent anthrax event and newly disclosed incidents have raised very serious questions about CDC's ability to safeguard properly selected agents in its own labs. The CDC director has called the potential anthrax exposure a wake-up call. But our investigation has uncovered this is not CDC's first wake-up call. I'm not even sure wake-up call is the proper term. This is a gross and dangerous understatement. It was a potentially very dangerous failure. Wake-up call is catching something before the danger exists. Once a person is exposed to the serious pathogens, the danger is of a much higher magnitude. In 2006, CDC bioterrorism labs sent live anthrax to 2 outside labs on a mistaken belief that the shipped anthrax was inactivated. Later that same year, inadequate inactivation procedures led another CDC lab to inadvertently ship live botulinum to an outside lab. In 2009, CDC learned from newly available test methods that a strain of Brucella, which can cause a highly contagious infection, had been shipped to outside labs since 2001 because researchers had believed that it was a less dangerous strain. One must question the scientific qualifications of these scientists. Reports by government watchdogs demonstrate that these events are not isolated incidents. Between 2008 and 2010, the HHS Office of Inspector General, or OIG, issued 3 reports documenting concerns at CDC labs, such as ensuring physical security of select agents and ensuring personnel received required training. An audit in 2010 found that a CDC scientist discovered select agents in a drawer in an unsecured lab during a reorganization, and another CDC scientist found 16 vials of a select agent stored in an unsecured freezer that was reportedly left over from an outbreak investigation many years earlier. This is reminiscent of the recent discovery of smallpox vials in a storage room on the NIH campus. This smallpox was in a place that no one knew it was there, and it was also discovered by accident. In 2011, the OIG found that CDC did not monitor and enforce effectively certain select agent regulations at federal laboratories, including those at the CDC. In addition to the Inspector General audits, several GAO reports in recent years have raised concerns about oversight of high containment labs, including those at CDC. Despite the number of red flags, these incidents keep happening. We learned last Friday that CDC scientists in March shipped influenza strains to a Department of Agriculture lab that was contaminated with a very deadly flu virus. This cross-contamination was discovered on May 23, 2014, but it took 6 weeks for this to be reported to CDC leadership. What we have here is a pattern of recurring issues of complacency and a lax culture of safety. This is not sound science, and this will not be tolerated. These practices put the health of the American public at risk. It is sloppy, and it is unexcusable. Now, Dr. Frieden, I thank you for testifying today. I have questions about whether the corrective actions you have announced will ultimately solve the problems. We'll be looking forward to your testimony. CDC has already reassigned 1 lab official from his duties. Taking personnel actions, though, will not address problems that, based on the number of incidents and reports over the years, appear to be systemic. The CDC needs to reassure that proper policies are implemented and followed. And Dr. Frieden, you said last Friday that you were distressed about the delay in notification about the influenza shipments. I want to know if you are concerned about why CDC workers are not reporting everything, and whether you have reason to believe that they may be afraid to report these incidents. CDC is not going to solve human errors unless it gets as much information as possible from its own people. Since 2007, there have been 17 reports at CDC indicating that a worker was potentially exposed to a select agent or toxin. Thankfully, as far as we are aware, no one at CDC has become sick from improper handling of select agents. But CDC should not assume that its luck with these near-miss events will continue. Sooner or later, that luck will run out, and someone will get very sick or die. CDC needs to strengthen its safety procedures. The risks from these deadly pathogens require fail-safe mechanisms and redundancies similar to those used in other contexts, such as handling weapons. The subcommittee will also review the oversight system of federal laboratories, compliance with select agent regulations, and to explore the possibility of an independent agency to oversee the CDC labs. I thank all the witnesses for testifying today, and I now recognize the ranking member, Ms. Daggett.
Thank you very much, Mr. Chairman. Last month, scientists at CDC's Bratt Laboratory in Atlanta made a series of mistakes that could have had deadly consequences. They transferred anthrax spores to 2 other labs, potentially exposing dozens of individuals to anthrax. Luckily, nobody has yet fallen ill. Like all of us, I'm deeply troubled by what we've learned about this incident. How did it happen? CDC conducted its own internal investigation that identified numerous failures. There was no standard operating procedure for the analysis being conducted by the CDC scientists. There was no approved study plan. The scientists used a pathogenic strain of anthrax when a non-pathogenic strain could have been used. The scientists used unapproved sterilization techniques for pathogenic anthrax and then proceeded to transfer the material without confirming that it was inactive. This is obviously an alarming series of failures, but there were other problems at CDC that made this incident worse. CDC has provided to the committee a disturbing report from the U.S. Department of Agriculture Animal and Plant Health Inspection Service, APHIS. After the anthrax incident, APHIS conducted its own inspection of the facility. Inspectors identified serious problems in lab operations and decontamination procedures. They also detailed major problems with the CDC's response to the incident, reporting that the agency was inadequately prepared to handle the cleanup or to treat those who were potentially exposed. I think we can all agree the reports on this incident are bad. But what's even more troubling to me is that in context, they reveal a broad problem with the CDC safety culture. We've received report after report from GAO, the HHS, AIG, and APHIS offering a multitude of warnings and recommendations on operations of high containment labs. CDC's after-action report identified 4 other cases in the last decade where CDC shipped dangerous pathogens off-site. The Democratic committee staff prepared a memo describing the results from 6 different APHIS inspections at the CDC Roybal facility in 2013 and 14. Overall, in the 6 inspections, APHIS identified dozens of observations of concern, 29 related to facilities and equipment, 27 related to safety and security, and 39 related to documentation and record keeping. In some cases, the APHIS observations revealed that what appeared to be only paperwork problems, but in other cases, they found many more serious problems. They found reports of scientists using torn gloves and exhaust hoods blowing fumes in the wrong direction. Not one of these 6 inspections gave CDC a totally clean bill of health. Now, I'd like to make this memo part of the record, Mr. Chairman. I think your staff has seen it.
Without objection.
The record shows that CDC had ample warnings and should have been focused on the problems in their high containment labs long before the June anthrax release. I just don't understand why they didn't heed those warnings. Dr. Frieden has indicated that he was as surprised as anybody by the scope of the problems. And the fact, Dr. Frieden, you were so surprised is a problem in and of itself, because what it shows is that there's a fundamental problem with the culture of identifying and reporting safety problems up the chain of command. Now, I'm sorry to say, Mr. Chairman, these lab safety issues are not new to me or the committee. This is one of the detriments of having been on this committee for 18 years. We have had multiple hearings on this problem at the CDC over the years. In 2006 and 2007, we had terrible problems at the CDC facility in Fort Collins, Colorado, just north of my district, where we had vector-borne diseases that were being very sloppily handled. Fortunately, we built a new facility since then up in Fort Collins. It's a beautiful facility, and we are able to handle these diseases. But you know, these issues are not resolving themselves. And so while, Dr. Frieden, you've got a strong record at the CDC, I know you've got answers and recommendations, and you're acting aggressively to make sure this doesn't happen again. I appreciate that. We all appreciate that. But what we all need to know is what the plan is to change the culture at the CDC. We can't legislate. We can do a lot, but we can't legislate a culture change. It has to come from within the agency. I'm also glad to have GAO and APSIS witnesses here, because in retrospect, your warnings were prescient and should have been taken more seriously. I can assure you, these warnings are being taken very seriously right now, not just by the agency, but by the people here on this panel. Thank you very much, Mr.
Thank you, gentlemen. Time has expired. Now recognize the chairman of the full committee, Mr. Upton, for 5 minutes.
Well, thank you, Mr. Chairman. This is a very serious hearing for sure. 2 years ago, after allegations about problems in CDC's Building 18, the home to the world's deadliest agents and pathogens, this committee investigated whether the CDC was complying with federal safety requirements in the operation of its main lab facilities. In response to our concern, CDC Director Tom Frieden sent the committee a letter in September of 12. The CDC letter, which I'd like to include in the record, outlined the agency's efforts to ensure better oversight and safe handling of select agents at CDC labs. These measures included rigorous training, constant review of safety measures, multiple layers of engineering and operational systems. The letter also stated that a senior official who was not identified would be designated to report directly to the CDC director on safety at CDC labs. These measures sound very similar to the corrective actions that Dr. Frieden outlined last week to address the current lab crisis. Why should we believe this time that things are in fact going to be different? We asked CDC 2 years ago to identify each biosafety incident that had taken place at its main lab since January 1st of 2005. CDC provided the committee with a list back in 2012, but we now know from CDC's internal investigation released last Friday that in fact the list was not complete. Improper shipments of pathogens in 2006, including Anthrax, were not included in CDC's list of safety incidents that in fact was provided to this committee. CDC staff has now acknowledged to committee staff that the 2006 incidents, which were reported to the HHIG, should have been included. We don't know why they weren't. This raises the question of whether CDC leadership is receiving all the information about its own biosafety systems. Add to the possible anthrax exposure the delayed notice provided to CDC leadership about avian flu shipments and the discovery of smallpox vials in a cardboard box in an FDA storage room on the NIH campus, and these incidents no longer appear isolated. A dangerous, very dangerous pattern is emerging, and there's a lot of unknowns out there as well. When dealing with pathogens such as the ones being discussed today, unknowns are frankly unacceptable. What you don't know can hurt you. Why do these events keep happening? What's going to be next? CDC needs to solve the safety problem now as a team. The agency needs to get as much info as possible from its workers about true safety, of biosafety, the true state of biosafety at CDC, and keep this committee and the American people fully informed. There is zero tolerance for unlocked refrigerators and Ziploc bags. Those days have to be over. Yield to Marcia Blackburn.
I thank the chairman for yielding. I want to thank our panel for being here. And as you can hear, on a bipartisan basis, we have plenty of questions for you. We are deeply concerned about the incidents that have occurred at the federal labs that are run by Department of Health and Human Services, CDC, with the anthrax specimens. Dr. Frieden, we appreciate the time you spent with us last week, but I think we do have plenty of questions for you about the safety and the carefulness. You know, we would think that the priority would be safety and caring and making certain that you are tending to that culture of safety within these labs. NIH with the vials of smallpox, and the fact that this was in an unused portion of a storage room. Who all would have access to that? And then, of course, the cross-contamination of the influenza sample. We've all talked about the three of these events, and the fact that they have occurred within this framework of time, the fact that there seemed to be a dismissiveness of the serious nature of these occurrences. The fact that the CDC's own report pointed out some of the contributing factors in this, and the lack of a standard operating procedure and best practices, and the fact that this is not known among the employees at that agency. We know that there are some remediation measures that have been implemented, but the culture of safety or lack thereof continues to be a concern to us for public health. I yield back my time.
Thank you. Now recognize Mr. Waxman for 5 minutes.
Thank you very much, Mr. Chairman, for holding this hearing. I think it's important for us to investigate this incident involving the release of potentially viable anthrax on CDC's campus in Atlanta. When I was chairman of the Oversight Committee, we held hearings after the 2001 anthrax attacks. We looked at the safety of postal workers and the public in handling mail, and the Postal Service and CDC's response to those attacks. We had hearings again in 2003 and 2005, where we found there were still gaps in biological detection of anthrax and in communicating test results and risks to the public. Those hearings showed why CDC's work on identifying and containing public health risks from these types of biological agents is so important. But this work can also pose risks, and that's why this oversight hearing is important. In 2009, when I was chairman of the full committee, we held a hearing on the proliferation of high-containment biolabs and the lack of oversight over such facilities. Mr. Dingell also held a hearing in 2007, so this is not our first introduction to this subject. At our request, GAO, the Government Accountability Office, also looked into lab safety. GAO reported in a number of studies, one as recently as 2013, on the problems associated with the government's fragmented, piecemeal approach to these labs. No single agency has oversight over all high-containment biolabs. There are no national standards for operation, and we have no record of how many labs even exist. The Health and Human Services Inspector General also issued numerous reports on high-containment labs and their handling of select agents. The Inspector General identified issues with the treatment of select agents and the safety of the individuals working with these dangerous pathogens. The IG recommended that the Centers for Disease Control labs improve training for individuals handling select agents, improve record keeping, and take appropriate measures to improve safety. The American people count on the Centers for Disease Control to protect them, and we want to be able to assure them as CDC is conducting its research in safe and secure ways. I am supportive of Dr. Friesen's effort at CDC. We've worked with him on numerous issues in the last 5 years, and he has shown himself to be an effective leader and a strong communicator. And I appreciate the quick actions that he has taken in response to this incident. I'm encouraged to see that Dr. Frieden has appointed Dr. Michael Bell to oversee laboratory safety protocols and procedures. This investigation has shown us that CDC needs to change its safety culture, and I hope that Dr. Bell can help instill a new mindset at the agency. Still, I am concerned that it took the exposure of dozens of CDC staff to anthrax to finally spur CDC to action. So we want answers from the CDC about how this incident was allowed to happen in the first place. And I look forward to hearing from APHIS and GAO about the problems they've identified in the past, how CDC should implement their recommendations moving forward, and what role Congress should play in making sure that happens. Mr. Chairman, this is not the first hearing on the subject. We've looked at it before. We need now finally to be sure that all the recommendations that we've had are put in place so that we can stop something like this from happening again. Thank you, and I yield back my time.
Thank you. I'd now like to introduce the witnesses on the first panel for today's hearing. First, Dr. Thomas Frieden is the Director of the Centers for Disease Control and Prevention today. Dr. Frieden is accompanied by Mr. Joseph Henderson, who is the Deputy Director of the Office of Security and Emergency Preparedness at the Center for Disease Control. Dr. Giardick is the Associate Deputy Administrator of the Animal and Plant Health Inspection Services at the U.S. Department of Agriculture. Dr. Nancy Kingsbury is the Managing Director of Applied Research and Methods at the U.S. Government Accountability Office. And Dr. Gingrey, did you want to introduce someone who's from your district?
Mr. Chairman, thank you very much for giving me the opportunity. I know this witness is on the second panel, and it'll be a little while before we'll be hearing from the second panel, but it is an honor and a pleasure to introduce off of the second panel Sean Kaufman. Mr. Kaufman is the president and founding partner of a company called Behavioral-Based Improvement Solutions. His background is long-term employment with the CDC before forming his own company in my district, the 11th Congressional District of Georgia, in Woodstock, Georgia. And I would encourage all the members on both sides of the aisle, if you haven't had a chance, I know we try to read all of the testimony, but sometimes we skip one or two along the way. But I will assure you that the testimony, written testimony from Mr. Kaufman, really hits the nail right on the head in regard to this overall issue, and I would commend it to you. And I'm proud to introduce him to you in anticipation of the second panel. Mr. Chairman, thank you very much.
Thank you,
and I yield back.
Dr. Gingrey. To the panel, you are aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do any of you have objections to taking testimony under oath? All the witnesses indicate no. The chair then advises you all that you are under the rules of the House and the rules of the committee. You are entitled to be advised by counsel. Do any of you desire to be advised by counsel during today's testimony? All the witnesses indicate no. In that case, would you all please rise and raise your right hand, and I'll swear you in. Stand, please. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Thank you. All the witnesses answered the affirmative. You're now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. We now give a 5-minute written summary of your written statement. Dr. Frieden, you're recognized.
Chairman Murphy, Ranking Member DeGette. Chairman Murphy, Ranking Member DeGette, members of the subcommittee, thank you very much for this opportunity to appear before you. I'm Dr. Tom Frieden, Director of the CDC. With me is Mr. Joe Henderson, who heads our Office of Security, Safety, and Asset Management. I'll review the problems that have come to light in the past month and tell you what we're doing now to address improving lab safety. The fact that it appears that no one was harmed and that there were no releases does not excuse what happened. What happened was completely unacceptable. It should never have happened. If I leave you with just one thought about today's hearing as it relates to CDC, it is this. With the recent incidents, we recognize the pattern at CDC where we need to greatly improve the culture of safety and I am overseeing sweeping measures to improve that culture of safety. CDC works 24/7, and our scientists protect Americans from threats, including naturally occurring threats like Ebola and MERS and drug-resistant bacteria, and man-made threats such as anthrax. But we must do that work more safely, and we will. There's a recap of the recent incidents that's summarized in our report, which has been completed, and we're just at the outset of our investigation of the influenza contamination. I'd be pleased to go through the two diagrams that we've provided to the subcommittee, which outline what we know to date. But in brief, the anthrax incident shows deeply troubling problems: a lack of proper protocol, incorrect inactivation procedures, failure to ensure that we were transferring materials that were sterile when we thought they were sterile, use of a virulent strain when a non-dangerous form would have been appropriate. In the influenza cross-contamination, we're still trying to understand how the cross-contamination occurred and investigating how there could have been such a long delay in notification. The risk to employees from the anthrax exposure was at most very small, and the risk of release to the public was non-existent. But that does not change the fact that these were unacceptable events. They should never have happened. In the past, as the committee has outlined, there were a number of specific incidents, and I do believe that CDC staff worked hard to address the specific findings of past investigations. But I think we missed a critical pattern. Instead of just focusing on those, when we issued the anthrax report, we provided not only these two incidents, but the prior episodes of what has happened, because what we're seeing is a pattern that we missed, and the pattern is an insufficient culture of safety. We're now implementing every step we can to make sure that the problems are addressed comprehensively in order to protect our own workforce and to strengthen the culture of safety and to continue our work protecting Americans. I've taken a number of specific steps. I've issued a moratorium on the transfer of all biological materials outside of all BSL 3 and 4 laboratories at CDC. I've closed the 2 laboratories that were involved in this situation until we're sure that they can be reopened safely. I've appointed Dr. Michael Bell, a senior scientist, to be Director of Laboratory Safety, reporting directly to me as the single point of accountability. He will review the moratorium and lift it lab by lab when we're confident that that can be done safely. He will also facilitate expansion and use of that safety culture throughout CDC. CDC scientists are world famous for their rigor in scientific investigation, and we will now apply that same rigor to improving the safety in our own laboratories. I'm convening a high-level working group within CDC internally to advise us on every step of the process, and an external advisory group of outside experts who are top in the world to take a fresh look and see what we can do to do better. We'll look at every inactivation and transfer protocol and other protocols and improve them as needed. We'll look at future incidents, if they occur, with a command structure which should have been used earlier in the anthrax exposure. I will ensure that appropriate disciplinary is taken as indicated by our investigations, and will apply lessons learned from this experience to our function as a regulatory agency in our Select Agents regulatory program. In hindsight, we realized that we missed a crucial pattern, a pattern of incidents that reflected the need to improve the culture of safety at CDC. But as with many things, recognition is only the first step, and we're taking a number of additional actions to establish and strengthen a culture that prioritizes the safety of our own staff, encourages reporting of actual and potential situations that may place staff and others at risk, openly assesses those risks, and implements redundant systems to keep risks to the absolute minimum. Part of that culture will be increased reporting of problems or potential problems. One of the aspects of an effective culture of safety is rapid reporting of problems. So if we do uncover problems in the coming weeks and months, this may well be the result of strengthening our culture of safety rather than failing to address it. We have concrete actions underway to change processes that allow these incidents to happen, reduce the likelihood of an occurrence in the future, and apply the lessons broadly. We'll do everything possible to live up to the high standards that Congress and the American public rightfully expect us to achieve. I look forward to your questions, and thank you for inviting me to testify today and for your interest in this important topic.
Thank you. Dr. Dick, you're next. Make sure your microphone is on. You push it very close to your mouth. Thank you. It's not on. The green light. There you go.
Thank you.
Thank you.
Mr. Chairman and members of the subcommittee, thank you for the opportunity to testify today about the Animal and Plant Health Inspection Services inspection into the release of possibly live anthrax at the CDC's Royal campus. I'm Dr. Jerry Dick, Associate Administrator for APHIS within USDA. APHIS conducted a thorough inspection of the incident to learn how it happened and determine appropriate remedial measures. We will continue to monitor the CDC's response to ensure all necessary corrective action is taken, and that when work resumes at the laboratories, it will be done in full compliance with the health and safety of the employees and the public at the forefront. USDA was designated by Congress as the partner with CDC in the oversight of select agents because of our expertise and experience safely working with select agents over the past century through our efforts to prevent dangerous disease agents from impacting U.S. agriculture and the environment. For decades, APHIS has also safely operated high containment laboratories that handle select agents, including those of concern for human health. Our personnel are leading diagnosticians and experts in the effective working of high containment laboratories. To ensure objectivity, APHIS and CDC signed a memorandum of understanding in October of 2012, which makes APHIS the lead inspection agency for CDC entities. Since the MOU was finalized, APHIS has carried out 11 inspections of the 4 CDC laboratories. APHIS takes any potential release of a select agent or toxin very seriously, with a goal of quickly ensuring that the release is contained and determining what led to the release to ensure no future incidents. On June 13th, CDC officials discovered a potential release of anthrax and notified APHIS. CDC voluntarily closed impacted labs on June 16th. APHIS made its inspection a priority and quickly began its work to ensure that all select agents were secured and that there were no other breaches in biosafety or biosecurity. The specially trained APHIS inspection team of veterinarians and a plant pathologist spent nearly 2 weeks, beginning on June 23rd, conducting a facility review of the laboratories and interviews with CDC personnel. APHIS briefed CDC officials on July 2nd, outlining deficiencies so that they could immediately begin taking corrective actions. APHIS found that the laboratory did not use an adequate inactivation protocol and did not ensure that the protocol was in fact validated. The initial response to this incident by the CDC laboratories was inadequate, both in securing as well as disinfecting laboratories. For example, individuals without approval to handle select agents were able to access space containing or potentially contaminated with anthrax at least 4 days after the incident was discovered. We also found that employees did not have appropriate training in some instances. We found no clear management oversight of the incident at the labs and no clear single manager overseeing the overall CDC incident response, which resulted in employee confusion about how to respond. In addition, CDC's occupational health clinic was not prepared to respond to the potential exposure of a large number of workers. APHIS currently has in place a cease and desist order with the select agents and the toxins at the two impacted select agent laboratories. We will require that corrective actions be taken to ensure the integrity of these research programs. We have directed CDC to provide APHIS with its plan for coming into compliance by July 25th. And before allowing CDC to resume select agent work in the laboratories, APHIS will conduct a re-inspection to ensure that all corrective actions have been taken. Mr. Chairman, this concludes my testimony. I'd be happy to answer any questions that you or members of the subcommittee have.
Thank you, Dr. Dick. Dr. Kingsbury, you're recognized for 5 minutes. Please point that microphone very close to your mouth, a lot closer than that.
Thank you, Mr. Chairman, for inviting
really,
us to
ma'am, Dr.
testify.
Kingsbury, bring it back.
Pardon me?
Bring the mic really close, please.
Really close.
Really close. Thank you.
That better? Yeah. Okay. Thank you very much for inviting us to come to talk to you about some of our past work on biosafety issues. As Mr. Waxman noted in his statement, we've been doing this work for quite a while. We started with the original anthrax attacks, and we've gone on to a number of other issues over the years. Basically, our past work has a couple of major themes. One of them is a lack of strategic planning and oversight of the whole picture of biosafety laboratories. APHIS and CDC are only a part of that picture. And since 2001, there have been an increasing number of biosafety laboratories, both within that sector, but also across the whole government. There are 6 or 7 different agencies involved, and no one entity has been charged with developing a strategic plan. We became particularly concerned about that as budgets began to shrink, recognizing that the management and operation of these laboratories is an expensive venture, and if they're not properly maintained, other kinds of problems can arise. We've also observed that there's a continued lack of national standards for designing, constructing, commissioning, and operating these laboratories. There is guidance. The Biosafety and Microbiological and Biomedical Laboratories guidance is available, but it's not required, and there is no process by which an entity needs to make sure that they're following that guidance. We think this broader government perspective about both how many of these laboratories we need and for what purpose, and also a better framework for oversight is still needed. We have done some work since the most recent episode became public. We did take a team to Atlanta. I want to thank Dr. Frieden for his staff's cooperation with us when we were there, coming together with something I'm prepared to sit here and talk about on something like 10 days' notice is a bit of a challenge for us. But his staff was very good at providing everything we asked for. I'm not going to add very much to that debate. I think the 2 previous witnesses have covered the details pretty well. The one thing I would add, however, is while we agree that there is a requirement to have standard operating procedures that are reviewed at appropriate levels for biosafety, we believe it's also important that those procedures be validated. And by that we mean independently tested so that we can be assured that if these procedures are followed, there will be no further episodes. So I'll just add that one thought to the debate about the incident itself. Thank you very much, Mr. Chairman. That concludes my statement.
Thank you, Dr. Kingsbury. I'll now recognize myself for 5 minutes. Dr. Frieden, is anthrax a biological agent that has been or could be used in warfare?
Yes.
And the mishandling of anthrax can have some real consequences. If someone were sickened by anthrax, what would some of the symptoms be?
Anthrax can cause a variety of symptoms, but the most severe forms are respiratory anthrax, which can cause severe illness or death.
Oh, I have an image here of some lab, of some workers handling testing for anthrax, et cetera. One sees that they're generally I don't know if this is not in a lab, but some other workers investigating. But when I've toured labs, and thank you for this slide, there have been the number of levels there, what's required for breathing, for covering clothes, for cleaning before and after is pretty severe. I got to ask this question. Now, these aren't live, but this is a Ziploc bag. And I have to think, what in heaven's name would go through the minds of some scientists thinking a Ziploc bag is enough to protect someone from anthrax when you have other instances of all that paraphernalia someone has to wear when they're dealing with anthrax. Have you talked to these personnel involved with transporting anthrax and asked them why?
I have been directly involved in the investigation, and I will be directly involved in the remediation of the problems that we find. Many of the issues that are mentioned in the APHIS findings relate to what was done with the material that was believed to have been inactivated. So once the laboratory had said, here is killed anthrax, it was handled by the staff in those lower containment laboratories as if it were not infectious. Our subsequent studies suggest that it's likely that it was not, but the core error there was the failure to decontaminate.
But Dr. Frieden, this is like saying, I didn't know the gun was loaded, but somebody got shot. But you should always assume it is. For someone to say, well, I didn't think the anthrax was live, isn't acceptable. And quite frankly, I wonder if you have the ability to not only reprimand such personnel, but to fire them, to suspend them from working with pathogens that are deadly, or quite frankly, do they understand that the extent to which this went could have left them in a condition where they were charged with criminal negligence or negligent homicide or reckless endangerment? Do they understand the seriousness of this for the American public health?
I think first, your idea, Mr. Chairman, of a two-key system, as is used in other circumstances, is quite appropriate here, both within the high containment laboratories and to verify that stuff coming out is safe if it does come out, because stuff has to come out of those laboratories to be tested or worked with elsewhere. In terms of disciplinary proceedings, what we want to do is strike the right balance. On the one hand, we recognize the need to make sweeping improvements in our culture of safety, and part of that means that staff need to feel comfortable anytime saying, hey, there may be a problem here coming forward. At the same time, if our investigation finds that there is negligence, that people knowingly failed to report or took actions that were likely to or should have been known to endanger themselves or others, then we will take appropriate action.
Well, I'm looking here. Dr. Dick had said that the people who were not approved were able to handle select agents, were able to access space containing or potentially contaminated with anthrax at least through June 17th, 4 days after the incident was discovered. Now, my assumption is these scientists and their aides are pretty smart people, but it's extremely disturbing to think they're not thinking of this. But let me ask this. It's been a week since you learned about the March 2014 CDC shipment of H5N1 influenza, and there was a 6-week delay in notifying. Have you found out why there was a 6-week delay, and was there a cover-up involved in that, or is this bureaucratic hurdles are too high? What was the cause?
I've only gotten some very preliminary information on that. I will make a general point, however. When we look at emergencies in emergency departments or intensive care units in the healthcare sector, the biggest problem isn't usually a failure to respond effectively when people recognize there's an emergency. It's a failure to recognize that the situation is an emergency or something that requires immediate attention. But we haven't completed our investigation of that, and we will look at all possibilities.
Is there any kind of notification or alarm system that lets people know when there's been a release or a problem there?
There are multiple alarm systems within CDC. In this case, it was a cross-contamination of a culture. So somehow, and we haven't figured out how yet, a relatively low virulence avian influenza was cross-contaminated in our laboratory with the high pathogenic H5N1.
Well, I get more alarms going off when you try and walk out of Walmart with a shirt that hasn't been paid for. You see those happening all the time. Is there any evidence of cover-up here from employees not wanting to let someone else know that something else is
No, we've seen at this point no evidence of a cover-up, but we do see the need to strengthen the culture of safety that encourages reporting anytime there's a problem or potential problem so that we can assess it and take rapid and prompt action.
Thank you. I now recognize Ms. DeGette for 5 minutes.
Thank you, Mr. Chairman. Dr. Kingsbury, let me just make sure that I heard your testimony right. You testified that there's an increasing number of labs that are handling these bioagents, correct?
Correct.
And you said that there's really no one agency in charge. Is that correct?
Correct.
Now, you said that today, but in 2007, the GAO testified before this committee the same thing. No single government agency was responsible for tracking all of these labs.
That's correct.
That's correct, too. Dr. Frieden, are you aware of this finding by the GAO going back all the way to 2007?
Yes, I am.
And do you agree with Dr. Kingsbury that there are an increasing number of labs handling these bioagents?
If we look over the past 10 years or so, it is my understanding that there is an increasing number.
And do you agree with her that there's never been one agency in charge, despite the red flags going up all of these years?
There is a clear division of responsibilities between CDC and APHIS in terms of select agent oversight, inspection, and enforcement. Several years ago, at my direction, we turned over the inspection of CDC's laboratories, select agent laboratories, to APHIS, which has conducted them since that point. But the overarching issue of laboratory safety is one that does touch many parts of both the public sector and the non-governmental sector.
So are you saying that APHIS is in charge now since you put that into effect the last few years?
In terms of the inspection of laboratories which are working with select agents, there's a clear division of responsibility between ourselves and APHIS.
Does that mean APHIS is in charge, yes or no?
APHIS is in charge of investigating CDC's select agent laboratories. APHIS is not in charge of the overall enterprise.
So do you think we need to clarify who's going to be in charge of the overall enterprise?
We're certainly willing to look at every suggestion to improve laboratory safety and biosecurity.
Do you think it would be useful if we had one agency in charge of all of the inspections and making sure people were doing things in the right way?
I've seen several suggestions for how we could improve the process of BSL-3 oversight and select agent oversight, and my sense is that each of these ideas is certainly worth exploring.
What do you think about that, Dr. Kingsbury? Do you think it would be useful to have one agency in charge?
Well, we've said for a number of years, as you know, that there needs to be some entity in charge of a national strategy, not necessarily in charge of every laboratory in the country. The other thing I would
So you're saying an agency in charge of developing the protocols and how you're going to do this?
And ensuring biosafety and biosecurity. But the more important issue from a strategic point of view is how many of these laboratories do we really need, for what purpose, against what threat? One of the interesting things that I've become a little bit more sensitive to in the last few weeks is that the whole structure we have that CDC and APHIS are involved in is around the select agent agents. And there are a lot of other bugs out there in other laboratories that are not select agents that also need to be protected, and there's very little visibility about that sector of this enterprise.
And Dr. Frieden, I'm going to assume that you're going to agree with Dr. Kingsbury that it would be very useful to have national safety and security standards that would apply to everybody. Is that correct?
I'm not sure I understood the question. I'm sorry.
Okay. Well, I mean, what GAO says is that we don't have one single agency developing national biosafety and security standards, and as a result, we have all these labs doing this type of research, a proliferating number of labs, but there's no standard across, there's nobody developing standards across all those agencies.
I think there are many aspects of both biosafety and biosecurity which merit careful investigation, and if we can figure out better ways to do them, we're certainly completely open to that.
And do you think it should, the protocols should apply to everybody?
The protocols may be very specific for the different situations, but they should all adhere to the highest standard of safety.
Dr. Dick, what's your opinion of this?
Thank you, Congressman. I think that there should be a single oversight body. Right now, for the Select Agent Program, there is a single oversight body made up of the Division of Select Agents and Toxins at CDC. There is a single oversight body in agriculture that makes up the other half of that Select Agent Program. Together, we meet on a monthly basis. We have the directors and assistant directors of the programs that are in the two programs, and we have OGC and other council
Well,
present.
if that's the
and
case,
so-
why are we having all these problems then?
And so what we need, what we have, is a single set of biosafety and biosecurity regulations that are followed by both sides.
But we don't have that now? Is that what you're saying?
No, what I'm saying is that I think we currently do have that. I do agree with Dr. Frieden that eventually, after we're done with this investigation, we should take a very close look at all of the issues and see if there are updates that need to be made to biosafety and biosecurity.
Thank you. I think I now recognize Dr. Gingrey for 5 minutes. Questions?
Mr. Chairman, thank you. And I'm going to address my questions to this panel to Dr. Frieden. Dr. Frieden, thank you very much for being here and providing the subcommittee with your testimony. I actually have a number of questions for you, in fact 4, and I'll get right to those since time is of the essence. Firstly, can you please describe the policies and procedures CDC has in place to handle biosafety issues that may arise from human error, like what happened in the Bioterrorism Rapid Response and Advanced Technology Laboratory in Atlanta on June the 5th?
We have extensive policies and procedures, but what we are doing now is implementing a moratorium on all transfers out of BSL-3 and BSL-4 laboratories while we review each laboratory's policies and procedures to ensure that there's appropriate inactivation before any materials are transferred out.
And I appreciate that answer, and you explained that to us, I think, last week in an informal setting, and I think that's a good thing. That leads to my second question. What is the impact and the cost of the BRRAT laboratory shutdowns? If you shut down those 2 laboratories for X number of days, do you have a cost estimate in regard to them being offline for a period of time?
I don't have a cost estimate for that. The impact of the moratorium is potentially significant, and so we're working rapidly to rigorously assess protocols and where there are situations such as the diagnosis of drug-resistant tuberculosis or helping to control the Ebola outbreak or beginning work on next year's flu vaccine. We will work to ensure that we can do that safely in time. But there are real challenges with this moratorium. One of the things that the BRAT lab does, the lab that was associated with the anthrax incident, is to provide to the laboratory response network, a network of over 150 laboratories, proficiency testing to make sure that they can rapidly identify anthrax and other dangerous pathogens safely. So we'll figure out a way to do that safely in time.
Well, I would think time is of the essence in regard to cost, but as you say, safety is the most important factor. You got to get it right, and I certainly agree with that. Should inactivated select agents be added back to the select agent list?
I think that what we need to ensure is that any inactivation is done completely. Because once something is inactivated, it may be able to be used, it may be necessary to use that, for example, to diagnose it. And you wouldn't want to have to follow select agent requirements out diagnosing something in a hospital lab or a clinical lab or even in the field. But the key point here is to have that 2-key system that the chairman mentioned in that meeting, that 2-key system to make sure that when inactivation is undertaken, it is validated and verified that the materials are inactive.
The last question, Dr. Frieden. In your testimony, you noted you only learned of the March 13th, 2014 shipment from the CDC influenza lab of a virus that was cross-contaminated with H5N1 to a USDA laboratory on July the 9th. So that's from March 13th when it actually occurred to when you were informed or learned of it July the 9th. Can you please describe how you are going to improve communications of these incidents up and down the chain of command?
Thank you. In fact, it was the afternoon of our meeting, which was in the morning when I learned about this, if I remember correctly. What your question gets to is really the crux of the matter, which is how do we improve the culture of safety at CDC? And I think that's going to involve a number of steps that we think will succeed, but will take time. We need to encourage reporting. We We need to encourage all staff to take responsibility in addition to having a single point of accountability for laboratory safety. We need to have a clear vision of working safely. We are, after all, the prevention agency, and we want to apply that same rigor that we applied to our work in the field and in disease control to preventing any incident from happening in our laboratory. We also want to build on many of the organizational strengths and identify the laboratories that are doing this very well within CDC and identify the practices that they're taking that will prevent these incidents. And finally, I think coming up with ways to monitor progress and track progress and identifying what are called the critical control points. What are the flashpoints? What are the areas where problems may occur? And then developing redundant, effective, validated, monitored ways to address those critical control points, whether it's inactivation or transfer of materials or making sure that materials transferred only contain those materials. We have terrific scientists at CDC, and they are now focusing their creativity, their energy, their commitment on improving our culture of safety.
Dr. Frieden, thank you very much for that. And,
Thank
Mr.
you.
Chairman, I'll yield back my 30 seconds.
Thank you. Now recognize Mr. Waxman for 5 minutes.
Thank you, Mr. Chairman. Dr. Frieden, last Friday, when you released the CDC report on the anthrax incident, you announced you were imposing a moratorium on CDC transferring any biological samples out of any BSL-3 or BSL-4 labs until they had conducted a lab-by-lab assessment. Additionally, you closed the Bioterrorism Rapid Response and Advanced Technology, or the BRAT laboratory, and announced that it will remain closed until it is approved to reopen under safer conditions. These seem like appropriate interim steps until CDC can undertake a comprehensive safety review and ensure that the proper procedures and protocols are in place moving forward. Dr. Frieden, how long do you anticipate this moratorium lasting and the BRAT lab being closed?
The short answer to your question is as long as it takes to ensure that they can open safely. The longer answer is that there are some things that need to resume. For example, proficiency testing for select agents in the laboratory response network. And that's something that we will look at very carefully. But I'm committed that we will not open them until we can open them safely.
Mm-hmm. What steps are you taking to lift the moratorium and reopen the facilities? And when will you know, or how will you know when it's safe to do so?
I've appointed Dr. Michael Bell, who's a top expert at CDC, not only in laboratory science, but also in safety. He works within the Hospital Infection Control and Safety Unit of CDC to oversee a high-level working group reporting to me. And they will develop, in the next day or so, finalize criteria by which they will assess each of the laboratories. Then each laboratory will look at its own protocols and practices and determine whether they are validated, effective, and scientifically proven and implemented in a way that we can be sure they will be applied. And then each laboratory will apply to him for resumption and lifting of the moratorium. I will review his recommendations and ultimately approve laboratory by laboratory reopening of this process. I would just mention this is not a small thing, because many of our laboratories that have BSL-3 laboratories have adjacent BSL-2 laboratories, and much of their work has to be done in the BSL-2. So they inactivate in the BSL-3, then move it to the BSL-2. That work has all stopped at this point until we can ensure that we're doing it safely. And this is one of the things that really is a tipping point for improving the culture of safety at CDC.
One of the more disturbing findings of CDC's own report on this incident is that scientists use a pathogenic strain of anthrax when they could have used a non-pathogenic strain. Isn't that correct?
Yes, that is.
Well, when the moratorium is lifted and the BRAT lab is reopened, will you have clearer standards and protocols to make sure scientists are not unnecessarily using potentially dangerous strains of bacteria when it's not necessary?
Yes.
Okay. GAO and APHIS both conducted investigations of the BRAT laboratory following the June anthrax exposure. Dr. Kingsbury and Dr. Dick, you believe the moratorium and lab closure an appropriate response to this incident, don't you?
Yes, I do. Yes, I do.
Okay. We should not forget today that the reason CDC conducts their special agent research is to help keep the American public safe. CDC serves a critical role for studying dangerous pathogens and finding cures and vaccines for deadly diseases. These labs are critical to our nation's response to bioterrorism threats. So I'm interested in learning about how this moratorium and the lab closures are affecting the critical research that these labs were conducting. Dr. Frieden, how do the moratorium and lab closures limit CDC's research capabilities? What happens to the studies, some of which I'm guessing were operating on detailed schedules that were being conducted in the labs?
We're looking at the moratorium now in detail and identifying any laboratories which need to resume transfers for individual patient care or for public health response with highest priority. And we expect that those laboratories we will be able to get reopened for transfer very soon. But we've already heard from, for example, the laboratory that deals with drug-resistant tuberculosis, the laboratory that deals with Ebola, and the laboratory that deals with avian influenza, that they have deadlines coming up for either patient care or public health response, and we will address that very quickly, but we will always put safety first.
How do the closures and moratorium affect research occurring at other labs outside of the Roybal campus?
We provide proficiency testing and other materials to laboratories, and so there may be impacts on some of our partners. The one that we're most aware of now and will work to address before the deadline is provision of materials that companies need to make next year's flu vaccine, and we anticipate being able to do that on time.
My time has expired, but it seems to me that this protecting the safety and health of your scientists, the moratorium, and the lab closures appear to be the appropriate response. Thank you, Mr. Chairman.
Thank you. Gentleman's time has expired. Now recognized Mr. Barton for 5 minutes.
Thank you, Mr. Chairman. In answer to a previous question, Dr. Kingsbury raised the point about how many laboratories there are. The GAO has indicated that there are probably too many laboratories. My first question would be to you, Dr. Frieden. Why do we have so many laboratories, and are they all necessary?
I don't know that there's a right number of laboratories out there. Our job within CDC is to make sure that we only work with dangerous pathogens where it's necessary to do that, and that we do so safely. And we will be taking a fresh look at everywhere we work with these pathogens internally at CDC to make sure that it's kept to the minimum necessary to serve the function of responding to infectious disease outbreaks. We still have anthrax in nature and respond to events like that. We still have Ebola with the largest outbreak in history now in West Africa. So the challenges we have are substantial. In terms of outside laboratories, our function in the Division of Select Agents and Toxins is to ensure that the laboratories that are there are operating safely.
Well, it would seem that one way to increase security would be to have fewer locations and fewer laboratories. I mean, if you're only, to use an extreme case, if you're trying to protect 100, that's going to be more difficult than if you're just trying to protect one. I don't know what the magic number is, but I think especially since the GAO has said there are probably too many, that would be worthy of a look-see. Dr. Kingsbury, do you have an opinion on that?
Well, I'm not sure we've actually said there may be too many. I think what we've actually said is nobody knows how many there are and nobody knows how many we need. And that goes beyond the scope
well, that's
of
even
CDC.
worse in a way.
Yeah, that goes beyond the scope of CDC and APHIS. And until there can be some kind of strategic look at what our requirements actually are, and they may be changing because of things like the Ebola outbreak and so forth, but somebody ought to be thinking about this, I think, a little bit more broadly than a single agency at a time, and that's basically our point.
Well, I'm asked the question, why are there 435 members of Congress? What's magic about 435? And the answer is that's as many seats or desks at the time they could put on the House floor.
Yeah.
When they got to 435, they couldn't put any more, and so it's an odd number, and they just stopped. But there's nothing magic about it.
That's
And
correct.
Same thing with the laboratory situation. I think there should be a strategic review, and the sooner the better. The staff has asked me to ask this question. It concerns the fact that beginning in 2012, the United States Department of Agriculture and the Center for Disease Control entered into a memorandum of understanding that allows the USDA Animal and Plant Health Inspection Service to inspect the CDC laboratories for compliance with the Federal Select Agent Program. Since the Select Agent Program was authorized in 2002, the CDC had been inspecting its own laboratory. Why did the CDC decide to turn its inspection process over to the Department of Agriculture? Was that because CDC didn't think that it could do the job itself? I'll ask Dr. Frieden that.
We've made a number of improvements both in our own laboratories and in our regulatory function through the Division of Select Agents and Toxins. And as I looked at this issue, I was concerned that there was at least the appearance that we couldn't be objective in inspecting our own laboratories. I didn't believe that was the case. I believe that one part of CDC, which has no organizational affiliation with another, could do that objectively, but I didn't think the appearance was a good idea, so I requested, and APHIS graciously agreed, to take over inspections of our own campus so that there wouldn't be that appearance of a problem.
If you had to do it over again, would you do the same thing? Was it a good decision to let the USDA do the inspection?
Yes, I believe that decision was appropriate. If I had it to do over again, I wish I had recognized the pattern of incidents that we now recognize, and which is why we put those prior incidents into our July 11th report.
Okay. With that, Mr. Chairman, I yield back. Or I can tell an Aggie joke. I mean, whatever. I yield back, Mr. Chairman.
Yield back. Thank you. Yields back. Now I'll recognize Ms. Castor for 5 minutes.
Thank you very much, Mr. Chairman and the Ranking Member, for calling this hearing today. I had the opportunity to visit the CDC last spring, and on the surface, they appear very serious about security, laboratory security, and yet every few years there are these lapses, and now an anthrax scare and an avian flu issue that was not reported in a timely manner. And, you know, we have very high expectations for everyone at the CDC. I'm impressed with everything that it's happening there, but for the high containment biological laboratories to have these lapses is not acceptable. So it's really troubling that although numerous government agencies over the past few years have warned CDC about problems at the high containment labs, it appears CDC has not heeded those warnings. We know of at least 14 separate reports, letters, and lab investigations from GAO, the U.S. Animal and Plant Health Inspection Service, and HHS Inspector General that documented a series of safety lapses and lack of oversight at CDC high containment labs. Dr. Kingsbury, your testimony is invaluable here. Can you tell us more about the concerns GAO has identified with regard to safety lapses at the high containment labs? You've said now someone has got to look at the number of labs across the country as well. Who is that? What entity is that? What are your recommendations there?
I wish I was in a position to say I know the answer to that. One of the difficulties that we've faced in making that suggestion is that when you look around the government, because they are being built and managed across multiple agencies, and each agency has its own mission and its own focus, it's difficult to think about who would be the single agency. We have discussed the issue with the Office of Science and Technology Policy at the White House, but while they have some overarching responsibilities, they don't have staff and management officials that would permit actually doing it that way. So we don't really have a good answer to that question, but we think it's worth just keeping the issue on the table, particularly in tight budget times.
Right, and you mentioned in your opening statement that you have heightened concerns because of budget cuts. Talk a little bit about that. Is there a particular area we should be focused on?
Well, it's just that, as I said in my statement, the management and the building and management and upgrade of these kinds of laboratories is relatively expensive compared to just building ordinary buildings. And so if we're going to have X number of laboratories, I would like to see the strategy that was going to permit us, even in tight budget times, to continue to fund them, to continue to upgrade them when necessary, and to manage the biosafety and biosecurity programs that are necessary to keep them safe. So that total picture just isn't available now, and that worries us.
Okay. Dr. Dick, do you think this has anything to do with budget cuts?
I don't believe that it has anything to do directly with budget cuts. We've been able to accomplish our mission in support of the Select Agent program over the recent years and provide the funding that's necessary.
Okay. And before the June anthrax incident, APHIS conducted at least 6 separate investigations at CDC's Roybal campus facilities in 2013 and 2014. Can you summarize your findings in those investigations?
Yeah, I think there were a number of findings that some of which were found in the recent finding, some of which were not. Simple things that people would maybe think are simple, like unlocked refrigerators, those kinds of things, up to and including more serious incidents, if you will, around invalidation protocols not being up to date.
And Dr. Friedman, it's troubling with, I mean, this has gone on for years now with GAO, APHIS, the Inspector General. Outside experts have been calling attention to these issues, and I'm encouraged because you've been forthcoming in your statements. You haven't been defensive, but what is your current action plan now going forward in detail? Is there a culture among researchers? What is it, and get specific for us from this day forward with these recommendations? What are you going to do in the time frame? Thank you.
Well, first, I think for past incidents, the staff at CDC and the scientists did take the reports seriously and did respond to those individual reports. What we missed was a pattern. And you're absolutely right that that pattern was an inadequate culture of safety. So the overarching challenge now is to ensure that we establish and strengthen a culture of safety in all of our laboratories throughout all of CDC. And there are a number of steps that we're beginning to do that. The first is the moratorium, so that we can stop and think about that particular procedure of inactivation and make sure it's done right. The appointment of a single point of accountability for laboratory safety throughout CDC, the establishment of a working group that person and Mr. Henderson will lead, the invitation to an external advisory group, and I intend to invite some of the leading independent experts of the country by the end of this week to serve on that advisory group for CDC. A hard look at all of the critical control points where there may be a problem with lab safety, and reviewing to make sure that we have protocols in place that are validated and verified. It gets back to that trust but verify approach. We need to make sure that we are empowering our laboratory staff to report and to identify ways to improve safety and security. We also need to verify that that's happening.
Okay, thank you. Generally, this time has expired. Now recognize Ms. Blackburn of Tennessee for 5 minutes.
Thank you, Mr. Chairman. Dr. Frieden, I want to come back to you, and if you will go to tab 15, the USDA APHIS investigation, and let's look at that. This started 10 days after the event. There was 18 days after possible exposure. You had a lot of really awful basic errors. Even you admit there's not a culture of safety. There's not that double check system. And it is something that when you look at worker safety, how it was compromised, and then the management lacking the basic information on what substances to use to have the contamination cleaned up. So looking at this tab and that investigation, I want you to detail for the committee what new policies have been designed as a result of this, and how did CDC guarantee that the new policies are followed immediately, effective immediately. You know, our hospitals and organizations that get all sorts of new rules from HHS on Friday afternoons at 4 o'clock. They're effective immediately. So I want you to detail for us how you implemented that and what the new policies are.
So effective immediately, all transfers, not just from these two laboratories, but from every single BSL-3 and BSL-4 laboratory at CDC have been stopped. Effective immediately, these two laboratories, the BSL-3 part of the influenza laboratory and the BRAT lab for the bioterror response, have been closed. Those two laboratories will not be reopened until both APHIS and I are confident that they can be reopened safely. We've also appointed a single point of accountability to look at this and to review before we reopen, before we begin any more transfers, procedures that are in place to ensure that they can be done safely.
How could it possibly have transpired that your management team couldn't even decide on the formula of bleach to use to clean up the contamination, or to see whether the on-site clinic was thorough and consistent in examining the staff potentially exposed to the anthrax?
In the first week after the anthrax potential exposure was identified, we did not respond in the way that we would respond to an outside emergency. And that's one of our after-action findings, that when we deal with emergencies, whether it's Ebola or fungal meningitis or another problem, we activate our emergency operations center, or even if we don't activate it, we utilize the resources of that center to have a systematic, structured, intensive, immediate response. That wasn't done for the first week after the anthrax potential exposure, and that's something that we will be sure to do in the event of any such internal event in the future.
Let me ask you this. Did the management team get preferential treatment to the point that they were unaware that the staff was turned away?
No, absolutely not.
Okay, and then why didn't the staff feel confident in expressing their worries to their managers so that they could get adequate treatment?
I'm not certain of what's behind that. I do know that part of encouraging and strengthening the culture of safety is making sure that people are encouraged and, in fact, reinforced and rewarded for bringing forth problems if they think there are problems and potential problems.
Do you think it had to do with the existing work culture that was there at the CDC?
I think, at CDC, scientists are so used to risk. They go out into dangerous places where they're not sure what the risks are going to be, that sometimes if you work year in and year out with pathogens that are scary, you can get inured to that danger.
Okay, let me ask you another question. Once the June incident was discovered, why? Why did it take you so long to track down the anthrax, and why wasn't there a record of where this was stored?
Well, as soon as, in June 13th, as soon as we identified that there was the potential that any of the plates that were sent out of the containment lab were not sterile, we immediately recovered those plates and put them back in the secure facilities. That's the best of my understanding.
Why wasn't there a record of where it was stored, and why was it stored in unlocked refrigerators stuck in an unposted room or in hallways?
My understanding, and we'll have to confirm that in the coming days, is that those findings relate to primarily the materials that were believed to have been sterile and sent out of the laboratory. It's not as if there was anthrax cultures being kept in the lab in an unlocked, unsecured place. I think that the point there was that once that initial error was made of thinking something had been inactivated when it had not been or may not have been inactivated, then that material was then out of the containment space. That's my understanding.
Thank you. Mr. Chairman, I yield back.
All right, I now recognize Mr. Green of Texas for 5 minutes.
Thank you, Mr. Chairman. And first, of all our panel, there are a number of federal agencies that handle some of these substances, not just CDC. Is there a general protocol that all the agencies look at and coordinate handling these substances, Dr. Frieden? Or Dr.
When it comes to select agents, then both CDC and APHIS establish standards and then inspect and enforce those standards. Other than select agents, There are agency by agency or entity by entity approaches that may be specific to the type of research or to the type of agent.
Okay. So there is some umbrella type standard for all federal agencies.
For select agents, there is.
Okay. Dr. Kingsbury, can you summarize your recommendations for us, and can you elaborate on which of these recommendations would require congressional action?
If you're talking about our recommendations, I think that resolving this issue of whether there is a national strategy probably can't be done without congressional action, and it'll take some thought to get us there.
Okay. Dr. Frieden, do you agree with these recommendations? Will you be implementing them that you can within your control?
In terms of laboratory safety recommendations for CDC, we will do everything to implement these recommendations. The report that we released on July 11th has a number of steps that we are already beginning to implement.
Okay. Any of them require congressional action, or is that something you control within your agency?
At this point, I'm not aware of anything that would require congressional action for us to take appropriate steps.
Okay. Dr. Dick, do you have any recommendations that for Congress or CDC that Congress needs to deal with?
At this point in this investigation, we do not have anything that can't be controlled through the Select Agent Program and our work with CDC.
Okay. Dr. Frieden, does CDC, based on the findings in their report, have any recommendations to Congress? You have none for us?
We're focused at this point on doing our jobs as well as possible, ensuring that we strengthen laboratory safety throughout CDC and use the findings from this experience to strengthen our regulatory function through our Division of Select Agents and Toxins, which inspects and regulates hundreds of entities around the country that work with these materials.
Okay. Let me ask you about the CDC budget. And again, I've heard other questions from my colleagues that this is not a budget issue as much. Has CDC received adequate funding from Congress to conduct its safety mission? Period. Not obviously you have other missions. So.
I think the challenges for safety are more than just funding. There are a variety of issues in implementing safety policies and procedures, and I don't think the primary issue here is a lack of funding.
Okay. Some of the witnesses we've been hearing from today have stated in testimony that CDC employees need better training and that there's need to be better standard operating procedures, but that overall there is a problem with the culture at CDC. Dr. Frieden, how do you agree with these assertions?
I do agree with them. I think that while we have scientists who are the best in the world at what they do, they have not always applied that same rigor that they do to their scientific experiments to improving safety. And that's why we're taking a number of steps to strengthen the culture of safety at CDC. And part of that is to encourage reporting of potential or actual problems. And because of that, it is possible, though I don't know of anything at this point that I'm aware of, it is possible that in the coming weeks and months we'll hear of other things in the past or that occur, and that may be a reflection that we've strengthened that culture of safety rather than that we've failed to address it.
Well, if it's an issue of culture, and again, like you said, you have some great labs, and I'm familiar with some of them. Is it just because they deal with these dangerous substances so often, they get lax and they're more interested in what they're working with than maybe the safety of what they're dealing with?
I think that's a significant part of it, that if you work with something, even if it's a deadly microbe, day in and day out, year after year, you get a level of familiarity that may lead to doing things that you really shouldn't do. And that's why we have to have double checks in place, policies and protocols, training, and a culture of safety with the vision that we will work to minimize risk such that no worker and the public are never exposed to a risk that could have been prevented in our laboratories.
Well, and I guess that complacency, it needs to be monitored literally every day, 24/7, because of what you do. Is that part of what you're trying to do at CDC and with the guidance for other agencies?
Absolutely. That's what we've done by establishing a single point of accountability for laboratory safety, an empowered working group that will work with that individual, but emphasizing that even with that individual and even with that group, laboratory safety is really something that everyone who touches a laboratory needs to be conscious of and think of ways to continuously improve.
Okay. Well, Mr. Chairman, I would hope that we would have a follow-up in a few months to see the success. And again, it's almost like retraining some of the smartest people in the country to be, certain what they're doing with the substance they're dealing with. And I yield back my time.
I think that is a good idea to follow up, but I do want to also, Dr. Kingsbury, when you were responding to Mr. Green's question about other congressional authorization that would be required, can you get us this committee details on what that would be?
I don't actually have.
You have to have your microphone.
I don't actually have a basis on which to be specific about what might need to be done. I think we probably need to continue to work with your staff to talk through what some of the options might be going forward.
Thank you. Now, Mr. Harper is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you for holding this hearing on a very important issue. And certainly, some agencies can be dysfunctional, and there's no concern or no real harm in that. But the CDC is one that cannot be dysfunctional. So we're very concerned about safety within the labs for obviously the workers there, and certainly for the public on how we're going to address that. And if I could, Dr. Frieden, get you to refer to tab 7. That's a letter that you sent in September 2012 to the committee responding to concerns about CDC lab safety. In that, you stated that a senior official was designated to report directly to you about safety issues and those things there. Who was that senior official?
I will have to get back to you about that to get you the name and the details of what was done in pursuant to that letter.
Okay, then obviously the question would be, and I would hope you could have answered today, was who was that senior official and what were the results of that action? And then the question that perhaps you can answer now is, how is the appointment of Dr. Michael Bell as the new CDC point person on lab safety when we don't even know who the old point person was? How is that going to be more effective other than we know his name?
What I believe to be the case is that what we did in 2012, similar to what we did in other incidents, was we did address comprehensively the specific problems that were identified. So there were concerns about some airflow issues, there were concerns about some of the security issues in our laboratories, and while I would never say that we're 100% resolved on those things, we really focused on those particular problems. What we missed was the broader pattern. So that's what Dr. Bell is overseeing now.
So does this mean that Dr. Bell will now continue until that there will always be a point person? Is that what your plan?
Yes, Dr. Bell is the person now. We will transition that to a single point of accountability for lab safety. And one of the things that Dr. Bell and his group will do is to recommend where that entity should sit within CDC to be most effective.
Dr. Dick, the CDC reported that since 2007 there have been 2 surprise inspections of CDC, both performed by CDC's Division of Select Agents and Toxins before APHIS took over inspections of CDC labs. Since 2012, I'm showing that APHIS has conducted 11 inspections of CDC labs. I'd like to know, why hasn't APHIS conducted any surprise inspections of CDC labs, or have they done that?
Thank you for the question. We conduct surprise inspections to enforce compliance between renewal inspections, which is every 3 years. As we stated, we came on in late 2012 as the oversight entity for CDC. At Royable Lab, we actually have been there 7, if you include this last incident time, in that year and a half. So we have not had an opportunity to do a surprise inspection since we're there regularly.
So the last time a surprise inspection was done was when?
We have not done a surprise inspection prior to taking over in 2012. I'm not familiar with before that.
And obviously I won't ruin the surprise by asking when one is planned, but it does seem like we
intend to follow up on
that's a great tool to have.
Absolutely, and certainly first and foremost, we're going to be following up on the current incident with them and making a revisit when CDC indicates that they're ready for us to revisit. And then we'll be doing surprise inspections after that point.
Let's say that, and this is for you, Dr. Frieden, or for you, Dr. Dick, if it's determined that a dangerous biological agent has been stolen, who do you report that to?
So we have a protocol for dealing with theft. There has been no theft of a biological agent reported from either CDC or any of the regulated facilities in the 10 years of the program, to my knowledge. When there are concerns for potential theft or misplacement, we work with law enforcement, including the FBI, to do a joint investigation. I would just mention that our expansion of surprise inspections was something that we directed over the last few years at CDC because we felt that was very important to do.
So you said there have been no reports of stolen agents?
That's my understanding.
But what about missing biological agents?
There have been losses at certain facilities, and in those circumstances we also coordinate with the FBI. Usually it's an issue of inventory control. So as earlier we were talking about critical control points, such as inactivation of virulent pathogens, similarly inventory is a critical control point.
Yield back.
Thank you. I do want to ask clarification of Mr. Harper's question, though. When he asked about theft of an item, your inventory control is not so tight that someone could not walk. I mean, someone could take something, replicate it, and walk out with something. Am I correct on that?
Inventory control is one of the critical controls to prevent loss or theft. But there have been, to my knowledge, no thefts reported from any of the select agent regulated labs, including CDC's, over the past decade.
Well, there was one of the Army, one in Texas, I believe, a few years ago.
I'm not familiar with that.
Thank you. Mr. Tonko, you're recognized for 5 minutes.
Thank you, Mr. Chair. Welcome to our panelists. The CDC is responsible for registration and oversight of all laboratories that possess, use, or transfer select agents that could pose a threat to human health, while APHIS is responsible for those select agents that pose a threat to animal or plant health. Select agents that pose a threat to both human and animal health, like anthrax, are regulated by both CDC and APHIS. So that being said, Dr. Kingsbury, can you tell us what GAO has found with regard to the increase in the number of high containment biolabs?
We got that on. I'm not sure I understand your question. I think within the select agent program, I think there is information about how many laboratories there are, and they are regularly inspected, as these gentlemen have just been saying. Our concern about the national strategy is that there are a lot of other laboratories that deal with highly infectious pathogens that are not considered to be select agents, and nobody knows how many of those laboratories there are.
But with the high containment biolabs, is there, in that given category, is there an increase that has been measured by your review?
I mean, is there, I didn't hear the word.
Is there an increase in the number of?
There has been an increase since the anthrax attacks in 2001. The last time we actually tried to count them was 2 or 3 years ago, and I think at that point it looked like there were slightly fewer than there had been the year before, which we sort of think is maybe just a budget problem. But that, again, is the only ones that people are actually aware of. I think there are private entities and perhaps state government entities that have BSL-3 and BSL-4 laboratories that are not overseen in the same way, and that is of little concern to us.
Well, what accounts for the numbers, the growing numbers of these labs that you suggested are out there?
Well, following the anthrax attacks in 2001, there are a number of agencies whose missions touched on the issue of biological weapons and whether those pathogens could be used to attack our country. And so each within their own sphere developed a program to counter those possible threats. And each got funded by the Congress to build additional laboratories and so forth. So it's just a fragmented program that had a very strong rationale at the beginning, but right now I think there's perhaps a different rationale that might be articulated, but nobody is in charge of doing that.
So are there, with this increase in the number of labs and these various missions associated, what would your recommendations be to addressing
well, we've made recommendations that there should be a single entity that has responsibility for developing a national strategic plan and national standards for the operations of high containment laboratories. The dilemma is figuring out how to do that in the current environment with competing interests among the agencies involved and so forth. It's there's even a competing interest issue in the Congress, since different committees of the Congress have different jurisdictions over these different agencies. So it's a tough problem to solve, but we think it would be worth spending some time, even at a theoretical strategic level, to begin to address this issue and think through how we would go about doing it in the future.
And Dr. Frieden, what are your views here in terms of the growing numbers of these labs and just how to move forward with the activity here in the U.S.?
I do think this is a complicated topic for which there's probably not a quick and simple solution, but just logically, the more places work with dangerous pathogens goes on, the more possibility there is of accidents or accidental releases. So ensuring that the work that happens is happening in a safe environment is critical. And the key concept I think we have to apply is risk-benefit. I don't think we can ever guarantee zero risk for some of the things that are done, though we can do everything humanly possible to get that risk as low as possible. But we have to ensure that the benefit is something that's reasonably likely to occur.
Thank you. Thank you very much. With that, I yield back, Mr. Chair.
Thank you. Now recognize Mr. Griffith for 5 minutes.
Thank you, Mr. Chairman. I appreciate that, and appreciate you all being here today to testify to us. Dr. Frieden, if I could get you to turn to tab 5 in the booklet. And as you look at that, there at tab 5, that is the HHS Inspector General report regarding the CDC Roybal facility, which says it was sent to you. Have you seen this before at some point? Front page says it was sent to you. Okay. And then if I could direct you to page 5, and on page 5 it says that the Inspector General's office could not verify that 10 out of 30 sampled approved individuals for select agents had received the required training. And do you see that on that page?
Yes.
And likewise it says that that select agent inventory records are incomplete, and you also acknowledge that that's on that page?
Yes.
And then if you go over to page 6, the report says that that agents stored in areas, that there were agents stored in areas not listed in the registration. You see that at the top of the page as well, on page 6.
Yes.
Thank you. And one example given is a scientist found a vial of select agent in a drawer, and another scientist discovered 16 vials stored in an unsecured freezer. Do you see that in that paragraph?
Yes.
That area, yes. And the report on page 6 also states that there were unauthorized transfers and packages received by unapproved individuals. Now, my concern is this is at the Roybal facility. Weren't these the same kind of violations that then popped up and were found in subsequent inspections by the USDA in 2013 and 2014, and then revealed again in the matter that brings us here today in the anthrax and flu incidents of 2014? Aren't they the same types of problems?
The answer is yes and no. The specific problems that were found led to a specific response. For example, on security, we implemented layers of security. We strengthened the systems. We locked. We improved personal background checks and security. So in each of these, we
Let me
felt.
ask you this question. Did you all do a system-wide after these problems were discovered? Because we've got 2010, then we've got 2013, and earlier in 2014. Did you all ever do a system-wide recheck?
Not adequately. Okay. Not adequately. We addressed the specific problems, I believe, with a sincere effort to rectify them, but what we missed was the broader pattern that we are now addressing by strengthening our culture of safety in our labs.
All right, and I do appreciate that, and I know that you're having to answer a lot of tough questions, and I appreciate your demeanor here today. I do think that's appropriate and appreciated. That being said, let's look over at page 7, and then on top of page 8, there are 5 recommendations there. If you could read those out loud that take place, and then let me know if they were followed up on.
Well, I can shorten this by saying that the key one is the 5th, and the 5th has to do with confirming that materials are inactive before transferring them, and that was specifically what was not done in the anthrax incident. So if we had applied this broadly, this incident would not have happened. The specific, just to give you a sense of it, in 2006, the anthrax, the same laboratory, the Bratt lab, had a pretty similar incident, and that's why that's why I directed that it be put into our July 11th report. And after that incident, they implemented a standard operating procedure for that particular type of biological material leaving their laboratory. But when they had a different type of biological material leaving the same laboratory, they didn't apply that standard operating procedure that would have inactivated it. So I do think it's the lack of adequate pattern recognition that has led us, until these last few weeks, not to undertake the kind of comprehensive, sweeping change in and improvement in our laboratory safety culture that we're now implementing.
Well, I appreciate that. Now, what about the other 4? Number 5 may have been the most important, but could you look at the other 4?
The first has to do with physical security measures, and I believe we've taken a number of steps there. There are still steps that we need to do better on in that area, having to do with staff coming in and not swiping in every time.
And you've indicated you're going to up training, which was number 3. What about number 2?
Yes, I think we've made a great deal of progress on ensuring that only approved individuals are allowed access to select agents, and Mr. Henderson can speak more to that.
All right, we've got 20 seconds to do number 4.
Inventory is an area where we have done a number of things, but given the recent incident at NIH and the fact that inventory is a flashpoint, we will be reviewing all of our inventory work. It's a massive job to do it right, but we will do that as well.
Well, and I appreciate that. The safety of the American public rests in your hands. Thank you, and I yield back.
Thank you.
Thank you. Now I recognize Ms. Schakowsky for 5 minutes.
Thank you, Mr. Chairman, and I want to thank the witnesses. As you can see from the tone of this hearing, there is complete bipartisan concern about what happened here. And what I wanted to concentrate on is not the incidents themselves, but then the response, in particular to the anthrax release. The CDC report described delays in identification of potentially exposed individuals and potentially affected lab rooms, and communication of the possible release of anthrax to all CDC staff that may have been exposed, and that there was no clear lead for response to this incident in the first week. So, you know, I know you've discussed a number of these things, but it's the management piece. Once a problem was discovered, and so I wanted to ask you, Dr. Frieden, what was your response to this finding?
This was our finding, and we indicated that when we deal with outside events, and we're currently dealing, for example, with Ebola in West Africa, where we have the largest outbreak ever, we activate our Emergency Operations Center. Or sometimes we'll use the facilities of the Emergency Operations Center to manage our response more effectively. We should have done that the moment we learned of the potential exposure. What that allows us to do is break down a big problem into smaller problems and address them one by one. Communications, employee safety, clinical care, decontamination, scientific evaluation, investigation. And so instead of doing that in a systematic way, it was done unsystematically and not as well as it should have been done. In those first few days, which I remember vividly, we were really focused on the employees who may have been exposed and making sure that they got into care and got on treatment.
But it took a while to even identify who those people were.
Yes. In the effort to do that, we identified that we didn't have the kind of systems that were needed, or the systems that we had in place weren't used promptly. For example, viewing security camera coverage to see who had come into and left the facilities on time. That wasn't done because one part of the agency didn't know or didn't use those resources. The root cause of that problem was not activating our incident command system.
Okay, Dr. Dick, can you elaborate on that finding about response?
Yes, I think our findings were very similar to Dr. Frieden's. We had an independent team that came in during there was still ongoing investigation by CDC and their staff, and our select agent group was interviewing employees and workers from the various sections that were responding to this. We found very similar findings to those that he just indicated.
Okay. You know, I wanted to follow up for a second on what the chairman was saying about the possibility of even stealing something that is a threat. You know, in the smallpox incident, it turned out that the vials were discovered at NIH, but they could have been somewhere else. Nobody seemed to know, and that's really disturbing too. That, you know, who knows? Somebody could have taken them out. I mean, so I'm not sure when you say that nothing has been stolen, that it also says that nothing could have been stolen. You want to respond to that, Dr. Frieden?
Well, we have taken a number of steps to strengthen the security aspects of select agent registration. Those steps include suitability assessments for all people who work with Tier 1 agents. They include looking at cybersecurity issues and personal reliability, ongoing access of personnel who have access to Tier 1 agents, increased physical security standards, incident response plans, and ongoing training. So I do think that the concern for theft is real. Some of these organisms still occur in nature, and ensuring that where there are laboratories, not just in this country, but around the world that do tests on them.
Well, let's worry about this country right now, and smallpox, of course, would be a big concern. Let me just end with this, if I could, Mr. Chairman. Whenever I hear the word culture and a cultural problem, I know we have a real challenge on our hands. You know, hand washing changed the face of medicine. It's not sexy, and people don't win Nobel Prizes over that kind of thing, but it really, as part of the culture, has made our medical system much more successful. Huge advance. And so these kinds of small things that deal with culture and attitude and awareness of these kinds of very simple things, we need to really figure out, you need primarily to figure out how to make them part of the everyday thinking of your staff. And we're willing participants here. And I yield back.
Thank you.
Thank you. Now recognize Mr. Johnson of Ohio for 5 minutes.
Thank you, Mr. Chairman, and I too want to thank our witnesses for joining us today. Dr. Frieden, it looks like you're the guy on the hot seat. You're getting peppered with all the questions, and I've got a few for you as well. You know, the mission of CDC laboratories, as you well know, includes carrying out work to protect the American public against bioterrorist activities. Now, critical lab activities are shut down pending the outcome of your remedial evaluation and reform. So how will CDC be able to address any bioterrorism or other emergencies which might occur before they reopen?
There's just one particular laboratory that is shut. There are multiple other laboratories at CDC that continue their operation that would be able to respond to bioterrorist or potential bioterrorist incidents.
Okay, so there's no concern on your part that because of these CDC errors that we may be limiting our ability to protect the public?
No, I'm confident that the incidents that we saw did not cause any release of agents into the community. They most likely didn't cause any actual exposure to CDC staff, but they really are a tipping point in our recognition of the need to improve our laboratory safety. But we are still fully functional in terms of being able to respond to an event. It's just that step of sending something out of a high containment space into a lower containment space that I've issued a moratorium on, and we'll lift that laboratory by laboratory as soon as we're confident we can do that safely.
Okay. Is the CDC planning to use the National Science Advisory Board for Biosecurity as the external committee to advise CDC on laboratory quality and safety?
What I intend to do is to invite an external advisory group specific to look at CDC and specific to tell us every way they think we can do better.
Well, what about the National Science Advisory Board for Biosecurity? Are you going to be using them?
That is not our current plan, to the best of my understanding.
Okay, because NIH on Sunday purged almost half of the members from that board, and I was inquisitive about whether you knew about this, why the administration took this action, and whether or not NIH consulted. Do you use that advisory board for anything?
I would have to get back to you on our particular. It's primarily managed by NIH, so I would have to defer to them for the management of that group.
All right. Well, that's good. That eliminates one question for you then. For Dr. Dick, in light of the anthrax incident investigation APHIS recently completed, do you think that prior inspections of CDC laboratories were sufficient?
I do.
Okay. Well, given the fact that select agents were stored in undesignated places, shouldn't such problems have come to light fully as a result of prior inspections?
Yeah, I think the important thing to recognize is that when we review their protocols, the protocols were in place. And because of the primary cause of this incident, and that was that this bacteria was not inactivated, it was transferred to a laboratory that would not necessarily have to have a locked cabinet. And so therefore, when we provide our report on select agents, as was indicated earlier, we also report on those laboratories where that select agent went, in this case, not deactivated.
Okay. All right. Well, that concludes my questions, Mr. Chairman. I yield back the balance of my time.
Thank you. Now recognize Mr. Long for 5 minutes.
Thank you, Mr. Chairman. Dr. Frieden, are you familiar with this picture?
I certainly am.
Well, I'm going to turn 59 years old in less than a month. And this vial is dated 17 months before I was born. And apparently it was located in a cooler where?
On the NIH campus.
Last week.
A little over that.
And recent?
Yes.
Recently. So this vial of smallpox that's older than I am had been in a cooler, am I given to understand, in one location? I can't even imagine a cooler running for 60 years, 61 years.
My understanding is that it was a walk-in cold room that was used for storage.
And someone walked in and discovered the smallpox.
What happened was that laboratory, as I understand it, was transitioned from NIH to FDA many years ago when FDA took over some of those functions. FDA is moving into its new facilities. In the course of moving, it was doing a complete inventory of everything in its facility, and the workers there discovered a large box that had this vial and others in it.
These are workers like moving workers,
no, these
not
are like
scientists?
laboratory scientists.
Lab workers.
Laboratory scientists.
Okay.
Yes.
Well, recently there was a case of someone that wanted to remove information from the NSA, and he got in a position to do that. And with a $1,500 thumb drive, he was able to take all kinds of severe government secrets with him out of his position he had worked into. Does it bother you at all that people could, if they had cruelty, meanness in mind, that they could not get into a cooler like this and take a 61-year-old vial of smallpox?
We're certainly concerned that smallpox, which should not have been there, was there for many years. And we want to ensure that on our campus, and NIH is looking at their campus, and FDA at theirs, there are not other examples of collections, because this was a collection of organisms that are in place and in places where they shouldn't be. This particular box was clearly created by a scientist who was very experienced, or a group of scientists. The materials were essentially freeze-dried, or lyophilized is the scientific term for it, and then sealed in that ampule that you held up the picture of. And that was done before smallpox eradication was undertaken. So it was not done with malicious intent. It was done just to preserve something for future.
No, I know that, but
Yeah.
just the fact that this could lay around for
Sure.
61 years, I can't even conceive of that thought. But let me take you to a press conference last Friday, now that we've moved from 61 plus years ago. At a press conference last Friday, you indicated that the CDC does research to figure out how better to treat people if they're exposed and prevent it if they're exposed, and how better to prevent it through vaccination. You also stated the fact that anthrax continues to occur in nature, that anthrax has been used as a weapon. My question is this: how many CDC laboratory workers received the FDA-licensed anthrax vaccine prior to the anthrax incident last month as recommended by the CDC, its Advisory Committee on Immunization Practices Committee for Lab Workers, since 2002?
I would have to get back to you on the exact number, but we offer anthrax vaccine to anyone for whom anthrax vaccine is indicated. We don't require people to get vaccinated, but we offer it to anyone who might be exposed through their laboratory or epidemiologic work.
So you think that's a pretty active program? You would.
Oh, yes.
Do you have any idea how many? I know you say you have to get back to me, which is fine if you will. I appreciate it.
I'd have to get back to you.
Okay, because it's it's reported that you told Reuters on June 30th the fact that anthrax exposure was even a concern, or that it might have happened, is unacceptable. Employees should never have to be concerned about the safety from preventable exposures. And as you note, to date, more than 12 million doses of Anthrax, the FDA-licensed anthrax vaccine, have been administered to more than 3 million individuals. So if you can get back to me with that, I would appreciate it.
I will.
And with that, Mr. Chairman, I yield back.
Thank you. Now recognize Ms. Elmers of North Carolina for 5 minutes.
Thank you, Mr. Chairman, and thank you to our panel. This is a very good discussion, and I appreciate your candid responses. I think that at this point, the most important thing that we all can do is get to the bottom of it and correct the issues at hand so that these things don't happen again. I did want to clarify something. Dr. Frieden, there was a question posed to you about the number of missing possible toxic substances, and I know you had acknowledged that over time there has been an account of some missing but not stolen, correct? How do you determine, if something is missing, how do you determine that it absolutely was not stolen? And if anyone else on the panel would like to comment on that, I would appreciate it as well.
So to give you an example, there may have been a package that was sent from one location to another and had a select agent in it. It did not arrive at the second location. The FBI was involved in that investigation, and the FBI concluded in one particular case, as an example, that the package had been inadvertently destroyed. But it had not been stolen or lost. Is there anything you'd like to add to that, Mr. Henderson?
Just one thing I think is important is we take the notion of chain of custody very seriously, so we're always trying to be mindful of where the select agents are stored, and if they're in transport, we have eyes on them or somebody trusted to be with them as much as possible. Occasionally, Dr. Frieden's correct, there could be an accounting issue where something's been destroyed and they didn't complete the paperwork, and then we have to go and try to understand what happened. And there has been a couple of instances like that.
Okay. So, thank you for clarifying that for me. And then, again, getting back to just some of the toxic substances that have been found in, boxes that may not have, stated what they were, in a refrigerated walk-in storage or otherwise. when the NIH ran across their most recent problem, they put in place what they called a clean sweep, and I know you had said that there was a change, there was a transition between NIH and FDA. Were they already in the process? I mean, is that what the clean sweep is that you were talking about, or did they institute the clean sweep afterwards?
My understanding is that both NIH and FDA are doing complete inventory checks and follow up to the discovery of the smallpox vial.
Okay, so once that happened. So I guess my question for you is the CDC doing the same?
Yes, we will undertake a comprehensive inventory review at all of our facilities.
At all the facilities?
That is my understanding.
Including the one that's shut down now,
yes.
Obviously,
yes.
But all of them?
All of our yes.
Great.
All of our lab facilities.
Well, thank you. I have time if anyone wants to use it, Mr. Chairman, but I yield back right now if no one else wants my time.
Right. I believe that concludes our first panel. So I thank all the witnesses for coming today, and we'll just let you step away while we prepare the second panel. I'd also remind everybody that we will have some follow-up questions for you, so please get back to us in quick time.
Mr. Chairman, will you yield for 1 second?
Yes, glad to.
I would just hope that we would have this panel back in the fall after Dr. Frieden completes his investigation and puts his controls in place. I think it's really important for us to know what they're doing, and I know they're working hard on this.
I agree with that, and we would like to hear again, so we'll have you back. Well, while they're getting ready, I'll get to next panel introduced. We'll have Mr. Sean Kaufman, who's the president and founding partner of Behavioral-Based Improvement Solutions, LLC. We'll also have Dr. Richard Albright as Board of Governors Professor of Chemistry and Chemical Biology at Rutgers University and Laboratory Director at the Waxman Institute of Microbiology. While the witnesses are stepping up here, I will be swearing them in. Just whoever is sitting in your right seats there. I'm sorry, I don't know what that means. Mr. Kaufman, you ready? Where's Dr. Ebright?
Was he here?
The witness is AWOL, I guess. Well,
I don't. Was he here?
was
he checked in?
I don't know. What we may do to get going here, Mr. Kaufman, I may swear you in so you can get started on your testimony, and then we'll swear in Dr. Ebright when he returns. So you're aware the committee is holding an investigative hearing, and doing so has a practice of taking testimony under oath. Do you have any objections to testifying under oath? And advise you under the rules of the House, you can be advised by counsel. Do you have a desire to be advised by counsel during testimony today?
That is correct.
You do have a counsel with you?
I do not.
Okay, thank you. Could you please raise your right hand, and I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. You're now under oath, subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute written summary of, 5-minute summary of your written statement. Go ahead.
Fantastic. Thank you, Chairman Murphy, Ranking Member DeGette, and the members of the subcommittee. Thank you for the opportunity to be here to testify on the Centers for Disease Control and Prevention Anthrax laboratory incident. Let me begin by commending the CDC, specifically the actions taken to protect the workforce and inform the general public during this very serious issue. I stand by my belief that when someone does something wrong, we cannot forget what they have done right, and in general, we must not forget that CDC has an outstanding history of service. For over 10 years, I have been providing biosafety training programs for individuals working in high-containment laboratories. My background is in behavioral science, and I specialize in motivating individuals to behave and mitigate risks associated with infectious diseases. There are 3 main challenges we face when doing scientific research: the agent, the people working with the agent, and the organization where the work is being done. The first challenge of working safely with infectious agents has been, for decades, and can be appropriately mitigated. Effective engineering controls, personal protective equipment, and standard operating procedures are already in place. However, it is important to recognize that one person and one error, whether it's unintentional or intentional, can negate all these controls in an instant. This leads me to the second challenge we face when looking at safe science, and that is the people working with the agent. Human risk factors such as risk perceptions, attitudes, behavior, complacency, outrage, apathy, and perceived mastery must be addressed to sustain optimal performance of the scientific workforce. We must accept and learn from and control for human error in the laboratory environment. In other words, we must stop focusing on the who and start focusing on the why, how, and what went wrong, passing no judgment other than we are all human, which would lead to solutions minimizing further human error. Our final and greatest challenge is the existing social norms or safety culture within an organization. Let me repeat myself. The greatest challenge we face specific to safe science is not the agent, it is not the worker, it is the culture of the organization. The culture of an organization permits norms to be developed, and it is within these norms that behavior is either deemed acceptable or unacceptable. As a former proud CDC employee, I am very, very disappointed by what I am hearing. It has been and remains very clear that this issue is a systemic one or an organizational issue rather than an issue of a laboratory director and 2 scientists. I have become irritated by the unnecessary finger-pointing and statements surrounding disciplinary actions of scientists who worked in parallel with the culture of the organization and made an unintentional error. The incident highlights the need for scientific protocols to be reviewed and verified, ensuring they work and they can be done by those working in the laboratory. This incident highlights the need to ensure those protocols are followed, and if they are not, consequences aimed at minimizing future failures are immediately applied. This incident calls for more evidence-based biosafety research to determine what specifically works and minimize risks associated with the challenges that we face, which again are the agent, the people, and the organization. In the years I've been doing training, I have been forced to speak a common language around the world. No matter where you are in the United States of America or around the world, people can relate to the concept of neighborhood, house, and family. I have used a home sweet home approach for establishing a healthy culture in my laboratory trainings. Please consider this analogy. A laboratory is a home. The scientists working within the laboratory are a family. The scientific protocols are the house rules. If one member of the family breaks the house rules, it puts the whole family at risk. If breaking the rules is not addressed, the whole house is at risk and begins to affect other houses in the neighborhood. Let me clarify. If scientists don't follow their house rules, it impacts other laboratories within the organization. CDC is a neighborhood that houses hundreds of houses, or actually has hundreds of labs. If the neighborhood does not establish a set of ground rules for all the houses, then each house begins to do their own thing, and inevitably the neighborhood is at risk. Building a culture of safety starts with establishing a commitment to the residents, or the scientists, of that neighborhood or that organization. We don't banish family members for unintentional errors. We encourage homeowners or lab directors to come together and find solutions. We establish consequences for neighborhood members, scientists who blatantly choose to break neighborhood rules. We support each other, especially when unintentional accidents occur. We talk about incidents, not hide them, so the whole neighborhood learns and grows from them. We recognize that together we are safer. This commitment is contagious and spreads to homes throughout the neighborhood, and that includes laboratories throughout an organization. This is just the start of culture change, folks. The seed we plant today is what we will reap 5 years from now. Somewhere out there may be a scientist or an organization who finds something unexpected in a freezer, or as a human being makes an unintentional error. A choice has to be made. Do I report this or not? I ask this committee facilitate a process which encourages organizations to report incidents and accidents rather than punishing them for doing so. CDC remains a national treasure, and the United States of America remains a land of opportunity for scientists and biological research. Placing untested mandates as a result of this incident on scientists and institutions of research may not only push science and innovation outside of infectious disease research, but worse, it could shift it to other regions of the world. I ask this committee to continue to take leadership role while considering the implications of this hearing and future legislation. I look forward to your questions.
Thank you, Mr. Coffin. Dr. Ipper, you weren't available when I swore, so I'm going to have to swear you in, but first ask you, when we're doing an investigative hearing, we take testimony under oath. Do you have any objections to testifying under oath? And the chair always advises you, under the rules of the House and rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel today? In that case, would you please rise and raise your right hand? I'll swear you in. You swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Thank you. You're now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute verbal summary of your written statement.
Mr. Chairman, members of the committee, thank you for inviting me to discuss the 2014 CDC anthrax incident and its implications. I am Board of Governors Professor of Chemistry and Chemical Biology at Rutgers University and Laboratory Director at the Waxman Institute of Microbiology. I will discuss 3 topics. First, the 2014 CDC anthrax incident. Second, broader biosafety and biosecurity issues in CDC bioweapons agents laboratories, also known as select agent laboratories. And 3, broader biosafety and biosecurity issues at the more than 1,000 other government, academic, and corporate select agent laboratories across the U.S. that are regulated by the CDC. My assessments are based on information in published CDC, HHS OIG, USDA OIG, and GAO documents, published press reports, and on my knowledge of biosafety and biosecurity standards for work with bacterial pathogens. I turn first to the 2014 CDC anthrax incident. I note that the 2014 CDC anthrax incident did not involve one violation in one laboratory, but instead involved an entire series of violations. The 2014 CDC anthrax incident involved multiple violations of biosafety and biosecurity recommendations in each of 3 different CDC laboratories. There were at least 7 distinct violations in total. Had any of 3 violations in one CDC laboratory not occurred, the incident would not have occurred. Had any of 4 violations in 2 other CDC laboratories not occurred, the impact of the incident would have been mitigated. I note further that the incident reprised nearly exactly a 2004 incident. In the 2004 incident, workers at Southern Research Institute in Frederick, Maryland, used an inappropriate procedure to inactivate a sample of anthrax bacteria, used an inappropriate procedure to verify inactivation, and sent the putatively inert but actually viable anthrax bacteria to Oakland Children's Hospital, where 8 persons were exposed before learning that the anthrax bacteria were viable. The CDC, as the agency with regulatory responsibility for select agent work relevant to human health, investigated the 2004 Oakland anthrax incident, and in 2005 issued a report on the incident. The 2005 CDC report included revised biosafety and biosecurity recommendations both for laboratories that prepare and provide inactivated anthrax bacteria and for laboratories that receive and use those inactivated anthrax bacteria. Had the CDC implemented the recommendations in its own 2005 report, the 2014 CDC anthrax incident could not have occurred, but the CDC did not implement the recommendations in its 2005 report. The fact that the CDC in 2014 made exactly the same errors that had been made in the 2004 Oakland anthrax incident shows that the CDC did not learn from that incident. I turn now to biosafety and biosecurity in CDC select agent laboratories. I submit that the 2014 CDC anthrax incident is not an isolated incident, but is instead part of a pattern, and a pattern that could have been recognized a half-decade ago, and should have been. Last week's CDC report listed multiple other incidents, none previously disclosed to the public, in which CDC laboratories sent putatively inactivated or attenuated, but actually viable and virulent select agents to other laboratories. These previously undisclosed CDC select agent incidents are fundamentally similar to the 2014 incident. In particular, 2 previously undisclosed incidents from 2006 involved anthrax and appear to be essentially identical to the current incident. All of these incidents raise both safety and security concerns. I note further that HHS OIG audits have documented further biosafety and biosecurity violations in CDC Select Agent labs. HHS OIG audits of the CDC Select Agent labs in 2008, 2009, and 2010 reported major violations. These violations included failures to ensure physical security, failure to restrict access, and failures to document inventories. They also included the failure to provide required training to workers, with training being unverifiable for fully 1 in 3 workers in the most recent available report. Perhaps most egregiously, the violations included unauthorized transfers of Select Agent labs to other laboratories or individuals. I note further that press reports from 2007 through the present have documented further biosafety and biosecurity deficiencies in CDC Select Agent laboratories. Examples, just to summarize, include inadequate provisions for emergency backup power, failure to maintain negative pressure airflow in biocontainment areas, non-functioning doors, non-functioning door seals, jury-rigged repairs with duct tape, failure to close entry doors, failure to latch entry doors, failure to assign distinct key codes to the key cards for Select Agent laboratories, and in at least one case, the discovery of an unescorted, unauthorized person in a restricted area. Taken together, the available documents indicate that the CDC has not adequately ensured biosafety and biosecurity in its own labs and are consistent with pervasive and systematic violations of biosafety and biosecurity in its own labs. I turn now to biosafety and biosecurity at CDC.
Could you summarize up the rest of your statement here, because we're
regulated Select Agent labs. The CDC and the USDA have regulatory responsibility for biosafety and biosecurity in the approximately 1,000 other U.S. Select Agent labs, government, academic, and corporate. There is no basis for confidence that biosafety and biosecurity standards are higher or that Select Agent inspections are more stringent at CDC-regulated non-CDC Select Agent labs than in CDC Select Agent labs. There also is no basis for confidence that biosafety and biosecurity standards are higher or that Select Agent inspections are more stringent at USDA-regulated Select Agent laboratories than in CDC Select Agent laboratories. Deficiencies in Select Agent standards at these CDC-regulated and USDA-regulated other laboratories are amply documented in HHS and USDA OIG audits.
Doctor, you're way over time. I'm going to have to just give you 15 more seconds.
One final point, which is I note that the CDC and USDA not only perform and fund Select Agent work, but also regulate biosafety and biosecurity for Select Agent work. This represents a clear conflict of interest. This systematic, clear conflict of interest may at least partly account for the deficiencies that I've mentioned. Thank you.
I think the two witnesses will now recognize myself for 5 minutes. Mr. Kaufman, you specialize in the area of behavior and behavior change along those lines. We've heard from you and other witnesses today this culture of complacency is a concern. Congress has investigated at length problems of the Veterans Administration. We're outraged because of the care we have for our veterans, but we saw that there were cash incentives for people to cover things up, to shred them, to hide waiting lists. We also had in this committee hearings with Mary Barra, the CEO of General Motors. Americans were outraged about this, and it was described as the culture of complacency, or the GM nod. Now we see this behavior problem getting into an area of which before, if you weren't a veteran or if you didn't buy those Chevy cars, you were at least not at risk. But this, when you release a pathogen, it's pretty indiscriminate. It's just around anybody who's exposed to it. So does this routine familiarity around pathogens tend to lead people to cut some corners and just get complacent about this?
I think that there's and I believe you know this too, I think that there's a inherent risk in behavior in general. You overbehave, you run the risk of becoming complacent. You underbehave, you run the risk of being underprepared. I think it's a very kind of a balance, and that in essence is really in essence what professional development and training and assessments can be used for, is to keep that healthy balance in check. In this case, though, if we're talking about the anthrax incident in the laboratory, I don't believe that this was a complacency issue or even an incompetency issue. I believe this was a scientist that implemented a protocol from another laboratory where it was used for good purposes, and I'd love to share what those purposes are. And unfortunately, there was no process to vet that protocol. And so when it was adapted from one laboratory to another, the inactivation time it takes to kill one agent versus another is a lot more with the spore-forming BA or Bacillus anthracis than it was with the brucella.
But when we heard some of the things that Dr. Ebright was just saying too, the way the doors were handled, that we've heard about people being in an area that was not authorized to be there, that a key was left in a refrigerator. It seems to me there's several other elements here where rules are in place, and people are just downright sloppy.
Yeah, Chairman Murphy, I think the things that you were saying are very true, and they actually must be addressed and concerned, but I think they also have to be put into perspective. You know, this key in a freezer is almost like, and you used a loaded gun or a gun earlier in the session, it's almost like saying that I have a house, and inside my house I have a gun, and my house has a door with locks, and it also has a house alarm, and upstairs in the master bedroom is hidden a safe, and inside that safe is a gun with a trigger lock that has a key in it.
But that's not the case here. If a key was left in the refrigerator, if people can come into that area too, if people were all piggybacking on each other's card here, those are violations of rules.
Chairman Murphy, like I said, I'm not going to argue the fact that it's a problem, because it is. But I'm discussing the perspective, and I'm telling you, I've seen those refrigerators. They are not common practice refrigerators that people just go walking by. These refrigerators are in places where you actually have to have access. I came in as a civilian. I'm not related to CDC. I've been to the laboratory. I've seen these freezers. They're not.
Well, but the issue is how people behaved. You know, we're not the object there, and that's a question I had for Dr. Frieden before, is should someone be required to use their actual card? So only certain persons can get in who have the authorization. It records when they were in there. Absolutely. And in some cases, with the deadly pathogens, require two keys,
Absolutely.
two sets of eyes on that.
Absolutely.
But part of this, too, I'm not clear on what you're saying, Mr. Kaufman. I want to be clear on that in some cases, are you making excuses for the persons and saying there wasn't enough things were in protocol? I'm not sure what you're saying.
No, sir. I'm not making excuses. What I am saying is that there's a healthy respect for what truly is going on here, and I think we have to look at the spectrum. We can't be arrogant and say this is just what happens in science, but we also can't be living in an illusion where this is the end of the earth. We've got to stop all research. We've got to minimize and cut things, down to a certain number of laboratories as a result of what happens here. I think we have to take a balanced approach and take a look at really what happened and in the culture at which it happened. That's what I'm saying.
Dr. Ebright, you concur?
I disagree.
Can you please explain?
So these are problems of individuals, but they're problems of individuals acting in a context. That context has two components. The one is the laboratory culture. And we've talked several times, or heard several times today, about a culture of lax attitude toward safety. That is part of the problem. We've also heard several times today about researchers becoming inured to working with dangerous or hazardous materials. That is part of the problem. What hasn't been mentioned before with respect to culture is hubris. And hubris is fundamentally part of the problem here. A sense of the scientist that he or she should be able to proceed without restriction and without management. So these are all issues with the culture. But in addition to that culture, you have an institutional structure. You have institutional management, and then you have the oversight of that institution. I think these are even bigger problems that are even more significantly responsible for the issues that I described. I mentioned the fact that CDC and USDA regulate their own biosafety and biosecurity. They perform the work, they fund the work. That's an inherent conflict of interest. Until that regulatory responsibility is moved out of those two agencies and out of any agency that performs select agent research and funds select agent research, I believe you can predict with high confidence that the same types of problems, the same patterns, and the same cultures will remain in place in CDC labs, in USDA labs, and in the approximately 1,000 other labs they regulate.
Thank you. My time is way over. I'm going to now recognize Ms. DeGette for 5 minutes.
Thank you, Mr. Chairman. I'll follow up on your questions. Mr. Kaufman, I have no doubt that these individuals have no ill motives. They're well motivated. They're trying to do their research. And Dr. Ebright, I think you would agree with that as well.
I would.
But let me just put this in context. I don't know if you were here when we gave our opening statements. I've been on this subcommittee since 1997. And I've got to tell you that the reason why we're so concerned here is because this kind of practice keeps happening over and over again. It's not just one isolated incident. As our memo that I put into the record said, there were 6 inspections. APHIS identified 29 observations of concern of facilities and equipment, 27 related to safety and security, and 39 on documentation and record keeping. And a lot of times what we're dealing with in this situation is very, very extreme bioagents that could kill a number of people. And you're nodding your head, so I'm assuming you understand this, yes or no?
Yes, I do.
Okay. So what we're trying to figure out, and like I say, I think the people are trying to do their job. I think they're well motivated, but with all due respect, we are not overreacting here. This has got to be solved. So what I want to ask you, since you were here, is did you hear Ms. Kingsbury's testimony where she said that that we need to have one agency at least in charge of developing national standards?
Yes, I did.
And what do you think of that? She admitted that it's going to be difficult to do that because of overlapping jurisdictions. But would you agree that it's worth an effort to try to do that?
I know you like yes and no answers, and I'm trying to think. I agree that we should explore what we're doing today and where we could go in the future. Yes.
Okay. Dr. Embright, what do you think about that suggestion?
There definitely should be a single national agency that sets policy recommendations, policy standards, and advises on needs and how those needs should be met. There also should be a national entity that regulates and oversees the select agent work. They need not be the same, but they both need to be there.
And let me just say that we've seen this in this subcommittee, not just at CDC. We've also seen it in the labs. And we saw it at Los Alamos some years ago, where some very highly confidential nuclear data disappeared because a researcher took it home to his house. It's the same kind of, you call it hubris or whatever. It's an assumption that there's important research going on and that nothing bad is going to happen.
Correct.
And so what I think is that, and in fairness, I think what Dr. Frieden thinks too, is you need to put systems in place so that it's not relying on somebody to have that kind of judgment where really you should have a system. Would you agree with that?
Absolutely.
And Mr. Kaufman, would you also agree with that?
Absolutely.
Okay, great. Thanks, Mr. Chairman. I don't have anything further. Thank you for clarifying, and I'll yield back.
Thank you. Gentleman lady yields back now. Recognize Ms. Blackburn of Tennessee for 5 minutes.
Thank you, Mr. Chairman. I think we're all kind of on the same path here with our questions. Dr. Ebright, I want to come to you. Let's go back to the CDC report from the 2004 anthrax incident.
Yes.
And you mentioned that. And that incident stated inactivated anthrax should be cultured both at the preparing lab before shipment and at the research lab several days before use to ensure sterility. So did CDC follow their own advice in this? Okay, go ahead.
No, they did not. Apparently not in 2006, definitely not in 2014.
Okay, so what we have is a continued pattern of refusing to learn from their past mistakes.
Indeed, refusing to read their own reports and follow their own recommendations.
Okay. You are the director of a biomedical research lab.
Yes.
And you do some of this same work with dangerous pathogens. And how important is it to you that all personnel in your lab strictly follow your biosafety protocols, and that in order to follow those biosafety protocols, they have an understanding that they have that culture of safety that is lacking at CDC?
I think it's critically important, and for biosafety, working with biohazardous organisms at any level, 1, 2, 3, or 4, that message of safety has to come first. That safety training has to come first. And before any experiment is even begun, There has to be a process of risk assessment, risk-benefit assessment, in which the investigator enumerates the risks, enumerates the benefits, weighs the risks against the benefits, assesses that the risks are outweighed by the benefits, and that process needs to be reviewed by another set of eyes.
Do you follow this as standard operating procedure?
Yes, we do for our biohazard research.
Yes. Is it clearly understood from all of your personnel? Do they see this as written best practices, and do they understand that they are expected and required to follow?
They understand that they're expected and required to follow these practices. They're monitored in these practices, and the message consistently is that these agents require respect, and they must be handled with respect. And before any experiment, that risk-benefit assessment must occur.
And if one of your personnel failed to follow those protocols, what would you do to them?
Depending on the nature of the failure, they would face consequences up to and including termination.
Okay. And we don't see that pattern taking place at CDC.
We haven't seen evidence for it.
Okay. Do you think that CDC is in need of a major correction, and do you have advice for CDC on what that correction would be?
Many of the things that we heard Dr. Frieden suggest will be undertaken at the CDC are precisely the steps that are required at the CDC. The question is whether this time will be different from the previous time and the time before that and the time before that.
And if they did not do that, I think probably, according to what you've said, you would terminate the whole bunch.
Again, I'm not sure that in this particular case, personnel action won't be sufficient to resolve the issue. This issue is institutional and organizational.
Correct.
They cannot have the regulatory authority to regulate themselves. It simply doesn't work. It doesn't work in many areas of human endeavor, and it definitely doesn't work in this area.
Mr. Kaufman, anything to add to that?
I continue to stand by my belief that any type of, and my conviction, because over the last 10 years I have traveled the world, including several federal labs in the United States, and I have asked scientists to please report laboratory accidents and incidents so we have a chance to learn from them. And if we take this chance now and turn it into a punitive aspect against scientists that make unintentional injuries, it's well known that punishment does three things. It builds resentment, it teaches no new behavior, and it hides true behavior. And so if we're going to make decisions that are going to decrease risk in science, we better consider how we address incidents and accidents before doing so. Punitive actions, in my opinion, are not a way to go. Certainly not against a scientist that unintentionally makes a mistake. If a scientist willingly, and there are scientists that do that, go against SOPs, that's a completely different job issue than a scientist that is doing their job within a culture and does not go outside of the SOP that's provided to them.
Thank you. Mr. Chairman, I yield back.
I got a comment to that, Mr. Kaufman. It builds resentment. You got to be kidding me. You telling me these people with PhDs do not understand that anthrax is dangerous? Are you kidding me? They need more training? You make in your statement the CDC anthrax lab incident was also a result of training failure? Biosafety training for scientists working with high containment facilities consists of multiple phases, blah, blah, blah. Are you kidding me? Are you making excuses for these scientists? If they don't understand that anthrax is used for a weapon, its spores can kill people, it killed people and harmed people at the U.S. Capitol, then they shouldn't be working there. And it sounds like you're saying they need more training. Boo-hoo. This is a bad situation. And I don't think you understand the seriousness of this, and it sounds like you're making excuses. Look at this. Washington Post, today's cartoon. You think the employees at CDC are proud of this? Ha, ha, ha. It's funny. No, it's not. This is tragic. It could have been lethal for people. And I hear you telling Ms. Blackburn that we're going to build resentment. Oh, I'm sorry. I don't buy that at all.
May I comment? Thank you. Thank you, Chairman Murphy. I, again, am not defending what's going on with CDC. In fact, I've said that I'm disappointed, even as a former CDC.
Disappointed is not the right word. You should find this to be abhorrent. Any words other than yes or no, was it wrong or not wrong? We can make excuses for, Mary Barra sat here from GM and she said this was wrong. There's no question about it. Dr. Frieden said this was wrong. There's no gray zone in this. I don't get it. I'll let you respond to that.
I appreciate that. I know the individuals involved, and when I say training is needed and training is a solution, there are several phases of training, and on-the-job specific training, which includes SOP verification, is needed for scientists, which have been mentioned in previous panel aspects as well. I'm not making light of this situation. I'm not making light of this situation at all. I'm simply saying that if we choose to punish people who come forward when they make a mistake.
That's different. I'm not talking about
That's
punishment.
what I'm saying.
People, that's different. We want people to be willing to do that.
Thank you. That's
But
what
I
I'm
thought that you were saying here, and I think it is in your statements here too, they need more training.
They need
You don't need
on-the-job
training
specific
to know that this is bad. When you put anthrax in a Ziploc bag or any other pathogen, you don't need training to know that. So I've gone over. I want Mr. Griffith, you're recognized.
That is subjective.
Well, and I guess my concern is that what we have here is a series of reports that Dr. Ebright has brought out, some of the questioning that I did and others did earlier. We've had a series of reports that date back a good period of time, and yet the changes haven't been made, and so it's a concern. A mistake is one thing. Having a standard operating procedure which is so flawed that you have repeated mistakes is something that I have to agree with the chairman on. That's our problem. And I agree with you, Mr. Kaufman, you don't want to punish somebody who merely makes a mistake. You want them to come forward as quickly as possible and let's fix it. But you got to stop the same mistake happening over and over again. Dr. Ebright, how do we make these reforms happen this time? How do we do that? Because while CDC has to protect the American public from anthrax and other things, our job is to do oversight and make sure that they're doing their job. So how do we make it happen?
I think the two steps that Congress and the administration could follow to reduce the probability that this happens again in CDC's own labs and in the labs that CDC and USDA regulate outside those facilities. The two most important steps are first to reduce the number of select agent laboratories. The number of select agent personnel, the volume of select agent research increased by a factor of 20 to 40 over the last decade. That volume of registered individuals, that volume of activity needs to be rolled back to close to the level where it was at the beginning of that increase. That would represent taking the current 1,000 or more than 1,000 select agent labs in the U.S. and reducing it to 50.
All right, now let me ask you a question real quick. High containment, select agent, are those interchangeable terms or are they different?
They're very close to interchangeable.
Okay.
Most select agent research, particularly most research of consequence, is done at biosafety level 3. Biosafety levels 3 and 4 are considered high-level containment.
So your first recommendation is let's squeeze it back down to 50 instead of 1,000 of these select agent.
Roughly, the increase was a factor of 20 to 40. I would recommend we roll back a factor of 20 to a factor of 40. 1,000 divided by 20 is 50.
Okay.
1,000 divided by 40 is 25.
All right.
So that, I believe, is the single easiest, single fastest, and certainly most economical approach.
And you
to
had a
resolve
second because obviously my
okay,
time
last
is somewhat
one
limited.
is independent entity that carries out the regulation and oversight of biosafety and biosecurity in those labs. Not an agency that performs the work, not an agency that funds the work.
Okay. Now, you've said we need to scale back, but let me ask you, why has there been an expansion? And the phrasing that I have is the high containment laboratories. You said they're close. Why has there been such a great expansion?
So it was in large measure, essentially in whole, a response to the 2001 anthrax mailings. At the time of the 2001 anthrax mailings, it was understandable because it was expected here and elsewhere that the U.S. was under attack with a biological weapon from a foreign source. It was expected that biology would be put on a mobilization footing to address this threat. we expanded by a factor of 20 to 40. Now, more than a decade later, more than a decade after it has become absolutely clear that the 2001 anthrax mailings did not come from a foreign source, and after it has become clear that the investigation believes it came from within the U.S. biodefense establishment, we have the strange situation that we have expanded that establishment by a factor of 20 to 40 without reason and without reassessment.
And the risks are self-evident?
The risks follow mathematically. When you increase the number of personnel by a factor of 20 to 40, particularly when you recruit people without prior experience, new to the field, you increase risks, and you increase those risks by a factor of 20 to 40 or more.
On those points, Mr. Kaufman, are you in agreement that we need to scale it back some?
I am not. I agree with GAO. I think that it's there's not enough information to make the decision to either back off or go up. We don't have a baseline. And I also would like to say that high containment laboratories are not built, the capacity of high containment laboratories are not built for the threats we just see today. They're built for the threats that we don't see coming around the corner tomorrow.
What about, let me switch gears and go and ask about the research implications or the implications from research of re-engineering pathogens, such as the experiments by University of Wisconsin scientists that generated a virus similar to the 1918 influenza outbreak that killed tens of thousands, maybe hundreds of thousands worldwide, and others ways to make H5N1 avian flu virus more contagious than ferrets. I mean, is this part of the expansion, or is this?
This is part of the expansion. Right. This is work that is funded as biodefense research, and this is a prime example of the culture of hubris. This is work that should not be performed, flat and blank, should not be performed. In those cases where elements of this work are deemed essential, when the research information could be obtained in no other way, then this work should only be performed in a very limited number of institutions, perhaps one or two nationally, and only after extensive review of risk-benefit weighing at the national level, and only under the most stringent safety and security standards.
I appreciate that very much. I appreciate both witnesses being here. Mr. Chairman, I appreciate having the hearing. I like the opportunities to learn, and I have learned a great deal from this hearing. Thank you so much.
I thank the gentleman for yielding back, and I certainly would encourage all members of this committee to go visit some of the labs around the country, particularly get to CDC headquarters and see for their own eyes how this works. And certainly for members of the CDC who may be listening, I hope they understand the seriousness of what Congress views today on this. I ask unanimous consent that the members' written opening statements be introduced in the record, and without objection, the documents be entered in the record. I also ask unanimous consent to put the document binder in the record, subject to redactions by staff. In conclusion, I want to thank all the witnesses and members that participated in today's hearing. Remind members they have 10 business days to submit questions for the record, and I ask that all the witnesses agree to respond promptly to the questions. Thank you very much. And with that, this hearing is adjourned.